哎，嗯，可以啊。喂，石江，喂，石江，哎，你方便吗？我问你个问题。哎，就是你之前用过 Zoom 会议吗？啊，你用过吗？काम तो कर ही डालो
So, hello everyone, can you hear me? I'm Professor Shu's postgraduate student, and I'm testing the stability of the Zoom.
Yeah,
Can you hear
I'm
me?
Professor Pradhan here.
Okay.
Nice meeting you.
Okay.
Good.
Nice to
What's the
meet you.
time? Yeah. What's the time in Shanghai?
It's 1 p.m. 1 p.m. right
1
now.
p.m. Okay.
Yeah. Can you watch my screen?
Yeah.
The screen,
I am able to watch your
the
screen.
content.
Yes. I'm able to watch your screen.
Okay.
Okay.
Thank you.
Thank you.
Okay. I'm just for a test. Thank you.
Yeah. Thank you.
दुकान में गया सब लोग में तो ऑपरेटर रन भी उतना मुश्किल है सिर्फ परचेस नहीं उनको छोटी छोटी मशीनें लगा देंगे फिर रात में पेड़ को अपने पार करता रहेगा फिर रिपोर्ट करता रहेगा मरीज बिल मिल जाएगा अपने आप देख लेगा सिटीज तैयार रहते हैं और वो रिटर्न भी नहीं जाता सामने तो फिर बाकी चीजें 60 मार्क्स करना है Okay, but brains वो brain की चलता करता है lines अब जो भी complicated है मान कितनी कर दिया टीटी वाली गलता चैनल देखना तो ठीक है हम लोग है ना मुझे कमेंट बस कर पाए सारे चीजें काम में बड़ी सारी रोटी खा रहे हैं ऑफिस 5 जी की मैं ऊपर बात 5 बजे तो वो अपना स्पेस का पैसा देगा कमरे सरकार में मिले उसको लोगों को कम्युनिटी स्टाफ भी करने ऊपर क्यों गई फोल्डर पुनीत के नाम से करा लो ठीक है अपने नाम से सेव करा लो खोलना सबसे आसान है स्क्रीन पे ब्लरिंग है थोड़ा सा नीचे स्क्रीन पे ब्लरिंग है No, don't leave this. तो देखिए
ये वो खुल गया है, उसमें वाला करिए। नहीं, अगर प्रैक्टिस खुलेगा ना ये
मैं करता हूँ इसको पहले कॉपी कर दूँ SGPGI NM SGPGI फाउंडेशन डॉक्टर प्रकाश के नाम से बनी है
वो तो पीजीआई जो रिकॉर्ड है उसी के साथ
ये वो दिखा रहे हैं एक मिनट ठीक 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 है
ये आपका सही निकल गया, मेरे वैसे यार ऐसे यार है।
आपके में साउंड वगैरह कुछ इश्यू है ठीक है ठीक है ठीक है कोई वीडियो तो नहीं है ना नहीं कुछ नहीं उसमें चीज नहीं इसका आ नहीं रहा हो तो बोलेगा
इसमें
एप्पल
नहीं था, फिल्म में आ गया, अब
आ
आ गया,
गया
आ गया, आ गया, आ गया।
वीडियो से आप तो रहोगे ना यहाँ पे हाँ मैं रहूँगा इसमें ठीक है सर हो गया ना ठीक
Username. Password 75.
Good morning, everyone. It is my privilege to welcome you all to the Foundation Day Symposium of Department of Nuclear Medicine. Today's theme is Nuclear Medicine Renaissance, Frontiers in Molecular Imaging and Radionuclide Therapy. To begin the proceedings, I invite Professor P.K. Pradhan to deliver the welcome address.
Professor Pradhan has been a guiding force in the academic and clinical development of nuclear medicine at this institute. I request Professor Pradhan to kindly take the dais. Let us welcome him with a warm round of applause.
Honorable dignitaries,
and esteemed faculty members and distinguished guests, dear colleagues and alumni and students. Good morning to one and all. I think it is my immense pleasure and a great honor to extend a warm and hearty welcome to each one of you present here today. As we gather to celebrate the momentous occasion, the 36th Foundation Day of the Department of Nuclear Medicine at Sanjay Gandhi Postgraduate Institute of Medical Science, Lucknow, we are truly privileged and to have with us today our esteemed director, Professor Radhakrishna Dhiman, whose visionary leadership continues to guide this prestigious institution to new heights. I also extend a special welcome to our esteemed Dean, Professor Manoj Jain, and and all other dignitaries gracing this occasion. And the orator of this symposium today will be Professor C.S. Bal, who is a distinguished professor, researcher, and educator across the globe. I think, and the journey of our department began in 1988 with humble beginnings, equipped with just 2 planar gamma cameras. That time it was a micro delta from Siemens, these gamma cameras. But that was what I had that time I was a resident. I think these are the best state-of-the-art system in the country. That's why I used to be NE to the SGPGI that time when I was in All India Institute. And then a dual photon X-ray absorptiometry, which will later on went to, because of the X-ray, went to the endocrine department's care. But we began with dual photon X-ray bone densitometer for the osteoporosis, and it was the only department of its kind in the region. And at that time, catering to the diagnostic and therapeutic needs of patients from Uttar Pradesh and neighboring states. As we will know, we are the most populous states. We are almost the 5th country in the world. And I think that was the need of the hour to have such a nuclear medicine department in this region, catering to the diagnostic and therapeutic nuclear medicine. Over the past 3 decades, we have not only kept pace and the rapid advancement in the field of nuclear medicine, but have emerged as one of the leading centers in the country. Our progress is a testament to the dedication and pioneers and of all the faculty members, including individuals like late Professor B.K. Das, then late Professor A.B. Sebatkar, who was from radiopharmacy, and then the Professor A.K. Sukla, who was from physics, and also Professor Sanjay Gambhir, and currently Professor Suganta Barai, Dr. Amida Varia, Professor Manish Dikshit, Dr. Manish Ora, and Dr. Aftab Hassan Najar, whose relentless efforts in patient care, research, and development have shaped the department legacy. We have expanded our capabilities to include state-of-the-art SPECT-CT and PET-CT imaging systems, and have established a cyclotron facility, allowing us to introduce novel radiolabel tracers, and perform over almost 10,000 patient procedures annually. Today is not just about celebrating the past 36 years. It is about acknowledging the contributions of every individual, faculty, staff, students, and alumni who have been a part of this incredible journey. It is also an opportunity to renew our pledge to continue striving to excellence in patient care, education, and research, embracing newer technology and pushing the boundaries of medical science. That's why we have invited also Professor Hong Cheng Si to speak about the newer technology like total body PET in this symposium. And as we celebrate this milestone, we look forward to the future with enthusiasm and a commitment to serving our community with high standards of care and dignity. Thank you all for being here to share this special day, especially our director, and the orator, Professor Bal, and also Professor Manju Jain, who is the Dean of the Institute. Your presence makes this occasion truly memorable. Thank you all for patient listening.
Thank you, sir, for your warm words. May I now request the Director of SGPGIMS, Padma Shri Awardee, Professor R.K. Dhiman, sir, to kindly join us on the dais. I now request our respected Dean, sir, Professor Manoj Jain. We welcome you on the stage, sir. It is our pleasure to call upon the stage Professor C.S. Bal, sir, who is an inspiration to all of us. Let us welcome all our distinguished guests with a warm round of applause. We now invite our guests for lighting the lamp.
New folder here. The folder is YouTube. जो पोस्टर है वो बता देंगे कौन सा कोड में किसी में ऐड से बंद करेंगे भी तैयार करके स्टूडेंट में कोल्ड पीपीटी लेके कोई करके अभी करना परमिशन के लिए पीपीटी के लिए नो पीपीटी कॉपी किया तो पहले संदीप ने कॉपी किया तो एक पूरा ये छोड़
It is now my honor to invite the Director of SGPGI, Padma Shri Awardee, Professor R.K. Dhiman, sir, to address the gathering.
Sir, your guidance has been instrumental in strengthening academic and clinical excellence at this institute.
Thank you very much. Good morning to everyone. Dr. Bal, Dr. Jan, Dr. Pradhan, and other esteemed colleagues of the Department of the Nuclear Medicine, students, delegates, ladies and gentlemen. First of all, I must congratulate Badhaiya for organizing 36th Foundation Day of your department. It gives a feeling, something very good, that you have passed 36 years with this department, of the department. And it has created wonders. It was the first department in the country which started giving the MD in medicine. Because I distinctly remember, it used to be some kind of the diploma from Delhi. But the MD in nuclear medicine started from here also. And this was the one department where everything was available. I don't know many things, but it had a SPAT, PAT, or even later on also that generates your radionucleotide. What do you call it? Cyclotron also. So very few departments having the cyclotron. So these are the things that we started actually about 36 years ago. Why I'm telling you the past? Because I was there in the SGPGI only as a student, DM student of the gastroenterology. And many times that we have to go to the nuclear medicine for imaging, nuclear medicine imaging also, particularly if there is a GI bleeding. I still remember RBC scanning. The many things that you can detect the obscure GI bleeding. GI means gastrointestinal bleeding. The patient is having the melena all the time. And you do upper GI, you do lower GI. At that time, capsule was not available, but enterocolysis, many things that we used to do at that time. And when you don't able to trace anything, then you ask your nuclear medicine colleague, at least tell me whether there is a bleeding or not. I think most sensitive test was RBC scan. Even if you do the angiography, that requires some the kind of the bleeding or some volume of the bleeding to detect the site. But RBC will tell you from it started, of course, with the movement or the mortality, it moves forward, but it gives you a definite diagnosis, yes, there is a bleeding. So it is about imaging as well as for the therapy also. I think it department or even the science, nuclear medicine has progressed many times actually. Now you have the state-of-the-art PET scans also, and that has something in combination with the AI also, and the next generation PET scans also. They are all available nowadays. You have the PET CT also, you have the PET MRI also, so many things actually. So this is the day, Dr. Pradhan and your colleagues. You have to think what do you next want? Because we are embarking upon now from tertiary care to the quaternary care also. So we want that your department should have the state-of-the-art equipments that commensurate basically the nowadays what is required. One, I have said you the PET MRI also, with AI also, so many things that you can do in your department. And another is the therapeutic actually. I am a hepatologist, so I know how to treat the hepatocellular carcinoma. So you do the tear actually with the yttrium isotope also. So we were doing when I was in Chandigarh, PGI also, and when I come over here, I think you are also doing over here. Yes. I don't know. So doing here. But there are several malignancies. One of my minister colleague over here, they were having the neuroendocrine tumor actually. And then you were thinking of giving the lutetium actually. That comes from the Germany also. Neuroendocrines, you have thyroid was from the very beginning also. So many tumors also, so much so that you have asked to start a DM in therapeutic nuclear medicine. I think it is a very positive step, and I strongly support the department to bring it, to continue with it, whatever infrastructure that you want in terms of the civil work or and in terms of the equipments. I promise you that we will do our best to provide it to you so that you remain number one department in the country. That is my wish also, because I have seen from the very beginning you should not lag behind. You should be on the frontiers actually. And in imaging whatever you want, I think you should come to me also. Uh, because we are asking to the government also that we want. Let us know also, maybe within a week or 10 days, so that we can pursue with it. And once again, thank you so much for organizing this uh, your foundation day. I think it is the day where you think what you have achieved and what you are going to achieve also. That is the vision for the 5 or 10 years also. That is the most important thing. And thank you, Dr. Pradhan, your colleagues, for inviting me. Thanks a lot.
Thank you, sir, for those inspiring words.
I now invite the Dean of SGPGIMS, Professor Manoj Jain sir, to address the gathering.
Thank you. Padma Shri Award, respected Professor R.K. Dhiman sir, C.S. Balaji, P.K. Pradhan, distinguished faculty, residents, and all guests. It's a matter of great pleasure that the department is celebrating its 36th Foundation Day Symposium, and I congratulate department with this theme, Nuclear Medicine Renaissance, Frontier in Molecular Medicine and Radionuclide Therapy. So as Dr. Pradhan has also mentioned, this was the first department in North India region and neighboring country, UP and neighboring country. In 1988, it was established to provide this high-end nuclear medicine facility. So this credit goes to our forebearers, Professor B.K. Das, Dr. Gambhir, and all other and our previous director also who had vision and established the department at that time. And that time it was the forefront. Still it is continuing to be leader and forefront in the teaching, training, providing patient care services in this region and state-of-art facilities available. So if we see this, there are many things department has achieved first time in the country. Cyclotron was established here, which was first time in North India region. And then metal-based radioisotope, which is first time in the country, even the world, few countries could develop this type of radioisotope for the therapy and diagnostic services. So department has been forefront in many, many ways and providing excellent services, providing oncology care, targeted therapy. So and there is immense future of this department also with the use of AI targeted therapy. This department will grow further, and our visionary director sir has already assured they are starting new DM courses, and many more achievement has to come. AI with the help of AI and targeted therapy, this department will grow further. So at last, I congratulate department for this great achievement and successful this CME. Thank you.
Thank you, sir, for your encouraging words. To commemorate this occasion, we have a special Foundation Day lecture on evolution of nuclear medicine at SGPGIMS, a journey through the years. I invite Professor Pradhan to share this remarkable journey with us.
Foundation Day.
You connected. Yes, connected. Yeah, sit down.
Good morning to all of you. I think I'll just speak on the evolution of nuclear medicine journey of us at Sanjay Gandhi, a journey through the years. And if you look to the timeline from 1988 to 2025, I think we have different milestones. The landmarks are mostly the department was established in 1988 with the two planar imaging and the spec CT. And that time we also had a head dome dedicated from the Japanese grant which came in. And in 2000, there was academic expansions. I think in 1992 onwards, the MD program established in the country as well as in Asia. And there was hardly any program that was a diploma available. And subsequently, it has already been emphasized that this is the first MD program in the country. And in 2000 onwards, this became academic expansions. We had 2 seats. And subsequently, we had in 2010 of SPEC CT and a PET CT. And almost we began our PET CT during that period in 2013. I think we lagged behind that time for 5 to 7 years in comparison to the country, but the PET CT came in. And the same time, we had the cyclotron also came in. But we could establish a little later. And 2020, the theranostic and precision medicine, now the current era is for theranostic. It is not only the importance of the country. I think Professor Bal has already shown the path for the theranostics across the globe. I think the courses have started 10 years back in India. I think the whole credit goes to definitely Professor Bal from All India Institute, who is here. And that's how the things starts moving. And now the globe is saying that we must have education and research in theranostics. I think we are way ahead. I think this is the time. And currently we are also, if you look to the landmarks, we had a foundation, then 3 gamma cameras and 2-bed radionuclide therapy ward. And now it is 10-bedded radionuclide therapy ward and 3 SPEC CT. Now we have a 4 SPEC CT and we have a 18 MeV cyclotron, which is the most high energy medical cyclotron in the country. And this is one of the state-of-the-art cyclotron with a solid state technology. And we are able to produce the copper 64, iodine 124, and also the zirconium 89. I think the whole world is now speaking of immune PET and immunotherapy, either in combination or alone. I think this is the most important area which should be focused. And it will always pave the path for the theranostics in combinations or isolatedly. And these are the landmarks. And we have the 10-bed radionuclide therapy ward. And these just came in, one SPEC CT, and it is there. I think if you look to the education part, I think this is which is very important for the next generation and capacity building. I think the first MD program started in 1992, then the PDCC program with renal pathology. I think it was very close to the soul of Professor Das with kidney and thyroid disorders. That's how they started in the 2002. And subsequently, the MSc program, initially with the BBEIU sandwich model. Then next, now we have acquired the MSc Nuclear Medicine Technology. I think the nuclear medicine needs both the clinicians as well as the technologists and also the trained nurses for radionuclide therapy. The PDCC radionuclide therapy and hybrid imaging program started in 2017, and the MSc radiopharmacy, it has been realized in the world now that the radiopharmacy is a very important component of the therapy. That's why the molecular imaging and therapy, it is more than a marriage to have molecular imaging and therapy. That's the kind of relationship. That's why there is a kind of word called theranostics. Everybody, if you seek, coming to the vision and mission, I think we had definitely it should be patient centric, and there should be clinical integration to it, and we should have interdisciplinary collaborative approach, and we should have excellence in educations and cutting edge research and innovations. I think obviously that will go with this kind of infrastructure. What do we aim, and what is our goal is basically to be ready for the world in theranostics with the molecular imaging and therapy. Coming to the current staff, so we have 6 faculty members, and we have 6 senior residents, and the junior residents are around 15. We are taking 6 seats per year, and a physicist is 1, and the nursing staffs are 8, and non-teaching staffs are 36. And we have the NPT program, PDCC correlative imaging, PDCC in radionuclide therapy, and MSc nuclear medicine technology, 8 seats, and MSc radiopharmacy. So PhD, 6 students are also there. So I think we are a hub of excellence in education, as well as to give the capacity building for the nation as well as for the globe. I think our objective is extremely clear, and the strength of students. If you look to the MD nuclear medicine, it is almost 6 students we are taking, initially 2 students, and subsequently you can see these strength of the students are almost constant, and the PhD seats are 6 students along with, and now we are continuing. This is what we are. So we have teaching facilities for PET radiopharmacy, cyclotron facility, gamma camera, and also gamma camera radiopharmacy. And we have a 10-bed isolation ward. Our classroom education goes to the lectures, journal clubs, seminars, interdepartmental collaborative meetings with the clinics, and the clinical learning and diagnostic centers are with the SPECT CT and the PET scanner. I think these are the photographs which have been taken, and you can appreciate that this is a general nuclear medicine radiopharmacy, and these are the PET CT facility in the right side and the SPECT CT facility of dual and gamma camera. And you can also see in the left hand, the 64 slice PET scanner. And this is the cardiac stress lab where we stress for nuclear cardiology imaging, for the myocardial perfusion imaging, and also in the right side, PET CT guided robotic biopsy. I think this is also an area because of the functional imaging. The CT scanner and the radiological imaging lags behind the PET scan. That's how the PET scan became more popular in 2000 Times magazine. You must have seen that it became extremely popular with the PET CT. And it basically increases the diagnostic sensitivity. That's how. And now, if there is no CT changes, still you can do a biopsy with the PET. That's how the robotic guided biopsy came in. And this is our 10-bedded ward. I think you can see. And this is our cyclotron facility where you can see. So these are the facility, and also on the right side, this is basically for the quality control PET radiopharmacy, and these are the quality control for PET radiopharmacy rooms. I think these are the pictures which we have inside our department. I think you can see, and the services we provide is a diagnostic as well as therapeutic, mostly with a nuclear cardiology, oncology, and the major chunk of PET CT is now to the oncology, both for a diagnosis as well as therapy, and the renal scan, nuclear nephrology, and endocrinology. I think the inception of nuclear medicine with a thyroid and subsequently developing with the nuclear endocrinology, we have a host of tests now for endocrinology, for adrenal, for thyroid, for everything almost in nuclear endocrinology. You can see that it is with the nuclear medicine now, and nuclear gastroenterology. And coming to the therapeutic disorders like thyroid diseases, I think everybody knows that since 1941, we are with the thyroid diseases, with the thyroid cancer, and benign, it is almost more than 8 decades. And the prostate cancer came in with the lutetium-177, the PSMA, and also the neuroendocrine tumor, and the cancer and the rheumatic bone and joint pains. For refractory rheumatoid arthritis, you can inject directly. This is called local regional therapy, radionuclide therapy, and also for neuroblastoma. That's why many endocrine tumors now can be treated like pheochromocytoma, paraganglioma. Following surgery or residual, you can treat them with radioisotopic techniques. And also for nuclear gastroenterology, I think we have hepatocellular carcinoma, and you can treat them with the TAR or with the chemotherapy. Also, people treat, but it has been found that the TAR is very, very effective. That's why the Sursphere and Therasphere, which is coming with the yttrium-90. And coming to the patient care, I think you can see the data. These are the OPD patients, which is going on increasing, and the gamma camera, and you see the patient's number. It is showing in the graph, which is increasing. I think the dip is because of the COVID, and the next it started rising. I think you can see this PET scan number, and the IPD is also increasing in a very rapid space, and the radionuclide therapy is also increasing in a very rapid pace. That's because, of course, definitely the radioisotopes are available now in the country. For your information, this is 1/15 of the cost according to the world. So they are very, very astonished. Wherever I go, when I speak, they say, how can you provide with so cheap medicine in the country? I told this is courtesy government of India. So that's what is I answer, because we have the lutetium production in a reactor and in the Brit, and that's how we could able to avail the lutetium-177, the PSMA, and lutetium-177 dotatate. Coming to the publications part, I think we have the publications. You can see these are all the publications, and we have intramural and extramural research projects also. And we have patents also, which is filed for a cyclobutan-based prostate cancer imaging. Coming to the awards, that most of the faculty members you can see, and also the residents have been awarded. So many with many recognitions, and with the different from the years from 2019 to 2025. And coming to the vision for the future, we must look ahead to the expansion of theranostic. And for theranostics to expand, I think we need what? We need newer molecules, newer tracers, and we also need imaging technology. And the total body PET have already came in. And I think we must embrace the newer technology and also the newer radiopharmaceuticals. Then only we can have a better stable marriage, and the productivity will be also much better. So whatever you aim for therapy to treatment patient-centric, that needs also some kind of innovations which can go simultaneously, and also the education will automatically grow in, and the capacity building. And coming to the artificial intelligence integration, I think this integration can come with the image, as well as also it is a workflow in the theranostic you can utilize for artificial intelligence. And I think this is the time now for global research collaborations. For in different, we have already embarked in with International Atomic Energy Agency with the coordinated research projects. We have many global collaborations to just begin with. And I think there is a need already there, and that's why I must acknowledge all the founding faculty members, which I have already told, and the current faculty and the staffs, the students and trainees, and the patients and the referring clinicians. I think with this, I must close my talk. Thank you for your patient listening.
Thank you so much, sir, for sharing this remarkable journey with us. It is now my pleasure to once again invite Professor P.K. Pradhan to introduce our distinguished international speaker, Professor Hongsheng Shi from Shanghai, China.
Professor Shi is a globally recognized expert in molecular imaging and total body PET technology.
Professor Hongsheng Shi, good morning.
Yeah, I'm here.
Okay, very good morning, Professor Shi.
Good morning.
Yeah, I think I'm just giving you few informations about you. Professor Shi is basically a professor and a director in Zhongshan Hospital in Shanghai, China. And he is also the president-elect of the Nuclear Medicine Society in China. And he is the first world authority for total body PET imaging. He has already written a book. I think he has published many papers. The most striking one is they have published from their group 60 published papers in EAJNM and also the Journal of Nuclear Medicine in USA, which has a very high impact factor journals. And they have also written many reviews. And the majority of their publications are in mostly JNM and EJNM, which influences across the world. And the Professor Shi is currently the chairman of that hospital, and along with a very good team members. And he is the almost leading experts in the whole globe for molecular imaging and how to do especially the dynamic imaging and dual PET with a very low dose of this. And he has also written a book on total body PET with his team members. I think with this, I think I must, Dr. C, now you can start your talk. I think I have finished your introductions to the audience about you.
Okay, thank you for introduction. It's great honor to have this opportunity to share our experience of the total body PET. At this time, I would like to thank Professor Prehandes give me these opportunities. So total body PET CT have been used in clinical nearly 7 years. So what's the difference of the total body PET from the conventional PET? So everyone knows that the conventional PET CT with very limited AFOV, probably not more than 35 centimeters. So although we got the whole body imaging, but we all know that that's one by one bed scan and then put them together to build the whole body PET imaging. At the different time point that the PET imaging, they totally different, they got the totally different the meaning of the different organs because that the time have the difference. And the second thing is that because that the short AFOV, so every byte scan only can acquisition very limited informations. So it always take a long time and it always inject a high dose. Otherwise, we could not get enough information in very limited that the time. But how can we deal with this problem? So that the total body PET emerged and solve all those problems. So for the total body PET CT right now, that's have that the 1 meter and 94 centimeter AFOV. So that means that just the one byte scan could cover that the whole body for most of the patient. And the second thing is that because it have that the long enough AFOV, so it could acquisite that all the different directions that the photons, so that the sensitivity increased almost 40 times compared with that the conventional PET CT. So because it have that the so high sensitivity, so there is some characteristics and clinical applications. The very important thing is that because it have the ultra high sensitivities, so we can inject that the low dose, such as that the 1 times dose. But what's the standard that the dose? Usually we just follow that the Europe guidelines. That means that for the FDG, we inject that 3.7 mg per kilograms. If we use that low dose in our centers, probably that's the half dose or 1 times dose. Sometimes that, although we inject that the full dose, but with the time, probably there is so many patients, but we could not perform that the scan just the 60 minutes later. Probably that's the 1.5 hours. But if we use that total body PET, no problem. Even that the 3 hours or 6 hours later inject of the full dose, we can get the qualified imaging. And sometimes we all know that for that conventional PET-CT scan, it always takes a long time. Probably that's more than 15 minutes. So some of the patients could not stand for so long time lay on the bed. How can we fast it? We can use that the 2 minutes. That's very important thing. Yes, we can do it, and we even can use that the 30-second scan. So sometimes we use the conventional PET-CT scan. We just using that the 3-dimensional imaging. That means that just with that actual sagittal and coronal imaging, that's the 3-dimensional. Could we get involved of that the time informations? That means that can we get that the dynamic scan for the total body PET? Yes, we can do it because that it could cover the whole body. So we can get the different organs at the blood flow and the radiotracer uptake proceeding at the same time. It really provides more information. Combined with the dynamic information with that static imaging, we can get that more accurate diagnosis or that the staging. So there are so many advantages of the total body PET over that the conventional PET-CT scan. How can we get these results? So we are very lucky. Our center is the first user of the total body PET in the world. So by now, have passed 60 years. We have finished more than 50,000 patients using this total body PET. During this time, including that 60,000 dynamic scan and 60,000 low dose scan and 2,000 low dose dual tracer studies. So we have finished so many that the clinical practice cases. So we summarized so many new series, and during this time we published so many papers, and we published 2 books, one in English and one in Chinese. So, and then I will show you some of the characteristics of total body PET in detail. So firstly, I would share that the 1 times dose of the total body PET scan. Just now I have introduced that we just follow that the Europe guidelines. That means that for the FDG, that the standard dose that probably that's the 3.7 mg per kilograms. So in our centers, we just try to realize that the 0.37 mg per kilogram that total body PET. So this is the one of the paper we published in the Journal of Nuclear Medicine in America. So if we inject that the 1 dose, we just using that the 8 minutes scan, that we can get that the imaging quality is as good as with that the full dose with the 2-minute acquisition. We compared with the imaging, is totally no difference. So that's just the thing that the total body PET is not less than that the conventional PET. We just want to get that the some of the advantages over that the conventional, just at the same levels. So we have published about 8 papers just using that the low dose scan. So what's the advantage? How about is the value in clinical practice for that the low dose? So it's really, really helpful. So for this case, this is a patient suffered from that cholangiocarcinomas and accept that the immunotherapies combined with the chemotherapies. If we just follow usually that the evaluation that the criteria probably after the first time that the 3 months we will perform the evaluation, but we can use the one-time dose. So every cycle of the immunotherapy we perform the total body PET. So this is the first baseline, and this is the second time. That means that just the one cycle of the immunotherapy, which can find that the lesions is really became that the size became small and the radiotracer uptake really decreased obviously. And the second time that the results even get better. So that's really good. So for that, the third time after that, the therapy, we found that compared with the previous one, that the lesion size became the increased and the radiotracer uptake increased a lot of. So just compared with the previous one, it seems like, oh, it's progressed. It's that probably this therapy method could not good for that patient, but without the middle times of the total body PET scan. We compared the last one with the baseline. We could get the result that, oh, it's okay. You get so many benefits. You can continue to use it. So that's the benefit using the ultra low dose. So we can let the patient perform more times PET CT scan in short time. So this is the tomography imaging. We can see those lesions that's more clearly. So that's the one-time dose that the patient get more benefits. So for some of the disease, that if we inject that the low dose, probably we can let the patient get more benefit because that the blood flow background will decrease the obviously. Everyone knows that the patient with Takayasu usually perform that MRI imaging to evaluate if that the patient have the active inflammations. Because that if the patient have the active inflammation, the patient will accept that the special therapies. So we use that the regular dose. Just the 2 hours later, the background is really higher. But 5 hours later, a little bit decreased, but it's really higher. So how, because we can use the one-time dose. So or we use the half dose. Probably we can let this kind of the disease that the diagnosis more easily. So we inject this kind of the patient just the one dose, the half dose, and then the 2 hours later and 5 hours later, we perform that the 2 times scan. So we can catch some of the slightly FDG uptake lesions. So that's more sensitive. And now it's accepted as that the guideline in China for that the Takayasu diagnosis and therapy response evaluation. So sometimes that the patient performed the conventional PET CT scan, but sometimes we found that some hours we found that it really need further information. But for the conventional PET CT, we could not do it. But for this patient suffered from the lymphoma. So in the morning, that's the 9:50, they perform the conventional PET. But in the evening, we found that we need further information. So we let the patient back to perform probably that's the 10 hours later scan. You can see that we really got the high quality imaging. It's really good enough to meet the request for the diagnosis. So without this the body PET, I think it's impossible. So sometimes it really take a long time. So some patients don't like to accept the total body PET. How fast could it be? Our team performed this study that even 30 seconds we just inject that the photos, we can get that the imaging. Probably it can meet the diagnosis, but we will lose some small lesions. But we all know that for that the low dose, that the fast scan is not our purpose. Our purpose is that if we can get that the imaging quality is good enough, that's the faster, that's the better. So for this patient that's with the big size, so we inject that the regular dose. When just 1 minute later, the patient could not stand it anymore. So we finished this scan just in 1 minute. You can find this imaging. All those that the informations that probably is enough for diagnosis. So that's the fast scan provide more informations. Because that the regular that the conventional PET CT is always take a long time. So during the acquisition, the patient would have that the motion. So if that the patient motion during the scan, that the image will be blurred, so we could not get the diagnosis informations. But for the total body PET, it's not it doesn't matter. We can rebuild that the imaging. We just rebuild that in the different time point, and then we just compared with each other, and then select one of the good imaging quality, and then we can get more information. Although it's not as good as without the motion, but anyway, it's really helpful to get that this diagnosis informations. And the dynamic scan is really very good for that the clinical applications. So usually we use FDG for so many years, but no one could tell us how about that the processing of the FDG biodistribution in the human body. So our team performed this study. We just evaluate that the photos that the FDG biodistribution in the human body, and then we just enrolled a group of the another kinds of the health volunteers to perform that one-time dose. So we compared with each other. Although we use that the one-time dose, that the biodistribution of FDG almost the same, but that's just the imaging. How about that the TAC curve for that the different organs? So for this one, this is the photos, and this is the one-time dose. So compared that the same organs in the different that the dose, this compared with that the photos, that the one-time dose, almost the TAC shape, the curve almost the same, except for that the peak value is lower than the photos. Otherwise, that all the information almost the same. That means that one-time dose is really good, could meet the diagnosis request. So sometimes we found so many lesions in the human body. Sometimes for this patient have the 2 lesions in the liver and the kidney. So perform that the FDG PET for that the staging. So just after that the acquisition, we found those lesions have more. This patient have more lesions, except for that the liver and the kidney. There is another pelvis, the lesion in the pelvis, and this is that the lower neck. So there are so many that the 2 new lesions. If we perform that the CT or MRI, that the enhanced imaging, probably we could not cover it at the same time. So the patient the second day to visit our department to perform that the whole body dynamic scan. We just inject that the one-time dose. So just according to that the TAC curve in that the different lesions. So we can get that the final more informations to give that the very more accurate diagnosis informations. So that's really helpful for that the 4D imaging. So I think in the future it will be used more and more popular. So right now that the cyanostics is really a hot topic. So we always think that we use one of the radio tracer to evaluate if that the patient could get more benefit from that the radio pharmaceutical therapies. But we just evaluate if that's the patient could get the benefit. But we never thought how about the patient get that benefit in the full futures, because that if that these lesions could accumulate this kind of the therapy radiopharmaceuticals, but the tumor heterogeneity would like that the patient will very quickly not used for that radiopharmaceutical. So in our size, we use that the one-stop dual tracer PET scan to evaluate if that the patient could get more benefit for that the radio therapies. Or that means that we just use that radiotherapy, radiotherapy all combined with the chemotherapies. For example, this patient, firstly, we inject that the FDG. After 1 hour later, we let the patient lay on the bed. After that, the static acquisition, we let the patient continue to lay on the bed, don't move. And then we inject that the FAPI immediately, and then 1 hour dynamic scan. Then we get that the first that's the FDG, and the second imaging is that the FDG and that the FAPI. So because that the two radio tracer imaging, so that's more accurate. Probably some of the lesions have a slightly FDG and slightly that's the FAPI that's the accumulate. But in the second day, probably we will lose it. But for that the dual tracer, we can get it. For this, the one-stop imaging, we just using that the one time of the CT scan, so that the radiation is significantly reduced. And also that the same day, so that the patient save a lot of time. And the potential that the benefit is that the dual tracer probably provide more information. But for the theranostics, we always emphasize that how about that the one kind of the radio tracer accumulate in the lesion. So we changed our the protocols. Firstly, we inject the FAPI, and then we perform that static imaging. After when we finish the static imaging, we inject the FDG, and then we perform 1 hour dynamic FDG scan, and then we just analyze this imaging. For that, the dual tracer is really provide more information about the tumors. So that's what I introduced. First, then I would summary in shortly. That's the low dose and short time and dynamic scan is really helpful. And the dual tracer imaging is really helpful for that the theranostics. So that's what I introduced today. Thank you for your attention. Thank you.
So please again share the slides.
Professor C, please share the slides again.
Okay.
Hello?
Yes, I will. Could you see it?
Hello?
Yes, I share it right now.
Okay. That was the last slide?
Yes, that's the last slide.
Oh, thank you very much. And
It's my pleasure.
okay, okay. Thank you very much for speaking to us. Okay?
Yeah, it's my pleasure.
Okay, okay.
Yes, finished.
Thank you, Professor Shi, for your informative lecture. The House is now open for any discussion and queries.
Yeah, Professor Shi, so it was a wonderful lecture. I just wanted to know. So please come. That's okay. Lecture, I just wanted to know. Such legislation like Paytm is not coming very popular cost and say I would feel the whole body paid. Is the incremental value actually proportionate to the benefit we will get? It could be research equipment, but it cannot be routine use and where the cost is almost tenfold high.
Sorry, I could not hear you clearly.
Yeah, I'm repeating the question again. Just like PET-MR, which could not be very popular in the current era of nuclear medicine except in few centers, and similarly whole body PET, the cost is almost tenfold than the benefit, incremental benefit may be 1.5 to 2 times. Does it justify investing $10 million versus $1 million and getting a minimally increased advantage except as a research tool?
Yeah, I think it's a very good question. So
just because justifies.
Yeah, so in China, that the PET MRI is more popular than total body PET. But you know that for the PET MRI is really that the short AFOA, probably not more than that the 35 centimeters. So if for that the static imaging is good, although they without that the CT radiations, but it always use that the photos, probably that's the more than four photos, because that is really have a long time acquisitions. So in our centers, we have that the total body PET and also have that the PET MRI. But we, for the diagnostics, we really prefer that the total body PET, especially for that the dual tracer.
Yeah, it's okay. What you are justifying, but the reason is that the healthcare model in different countries is different. It is in the US, it is all the insurance company pays and then get everything. The treatment cost of lutetium dotatate in US is $49,000 for one dose, which cost only $300 in India. Is only $300 versus $49,000. So it become popular because the hospitals get a lot of money from the insurance company. But in a public sector like India, where Sanjay Gandhi or All India Institute or in PGI Chandigarh, where the healthcare cost is supposed to be justified, why so much money we will invest in this equipment? Except minimal increment, 1.1 to 1.5 fold increase in the benefit of research output, then the routine day-to-day care can be done with a routine 35 millimeter or 35 centimeter field of view PET CT scanner, which is cost 1/10 of the cost of whole body. It is a good research tool, but will it justify tenfold increase in the cost in a public sector healthcare system?
Thank you so much, sir. Our next session addresses important updates in thyroid cancer management. Dr. Prakash Singh, who has spearheaded the nuclear medicine department in KGMC with several awards and publications to his name, will now be presenting the key changes in 88/2025 guidelines compared to 2015 recommendations. I would like to thank, first of all, Dr. Shi for the wonderful presentation and the insights in total body PET. Thank you so much, sir, for your insights.
Dr. Singh, I request you to take the podium.
क्या पीपीटी है क्या आपकी? कॉपी दिखानी थी आपने? कॉपी रुक जाइए. ये हटा दीजिए. सर
Good morning, respected chairperson, esteemed faculties, and dear colleagues. It is a moment of immense pride, gratitude, and emotional significance for me to be stand over here on the foundation day of our department in my alma mater, where I have received my training of nuclear medicine. I am deeply grateful to my teachers and faculties over here, under whose mentorship I was exposed to thyroid malignancies, radioactive iodine, and precision-based decision-making much before when the theranostic word became a global buzzword. It is my privilege to share 2025 American Thyroid Association Management Guideline for adult patients with differentiated thyroid cancer today. At first glance, thyroid cancer looks deceptively simple, but with a prevalence of about 2 million cases in 2021 and the rate growing by threefold, it doesn't look simple. Papillary thyroid cancer is the most prevalent one, with a female predisposition of 4.3:1, and the mean age at the diagnosis is approximate 42 years. Most of our patients live long, but they live with the disease. They live with the anxiety. So there was an urgent need for the paradigm shift. So American Thyroid Association decided to change their approach from what can be done, what should be done. A new framework for patient-centered management was initiated in place of previous one size fits all. So data framework for clinical management was initiated. Data acronym for diagnosis, assessment, treatment, and reassess response and adjust management. Before proceeding, just a quick look about the types of thyroid cancer. This classification is based on the histomorphology. Papillary thyroid cancer is the most common type, with characterized by distinctive nuclear features, can be infiltrative or capsulated. Follicular thyroid cancer, which requires vascular and capsular invasion. Oncocytic thyroid cancer, which is composed of greater than 75% oncocytic cells. Poorly differentiated thyroid cancer and high-grade thyroid cancer, which are classified on the basis of number of mitosis cell per 2 mmQ. Another new entry, non-invasive follicular thyroid neoplasm, which is encapsulated follicular growth pattern and absent zymoma bodies. One major question here arises, is non-invasive follicular thyroid neoplasm a cancer? Yes, it is a tumor with a very low malignant potential, much lower than the low-risk differentiated thyroid cancer. Completion thyroidectomy and radioactive ablations are not routinely indicated unless there are some predisposing factors like prior irradiation to the head or neck, obesity, or genomic predisposition. So we have seen that histomorphology tells about how our tumor looks. But we all have seen a very small thyroid cancer behaving aggressively without no obvious reason. The genomics lies the answer, why it behaves so aggressively. ATA 2025 gives a list of these mutations. It doesn't want us to become a molecular biologist, but here it wants us to understand the aggressiveness of tumor biology. Here we can understand with a 3-layer model. That is, one is the driver. Driver are like BRAF V600E, RAS mutation, and driver will ignite the start the journey, but they won't decide the destination. The destination will be decided by the accelerator. The accelerators are like TERT promoters, TP53, AKT1. And then the other combinations like CDK and 2A and CDK and 2B. So 882025 emphasizes that it's not the binary, it's the cumulative that carries the prognostic value. In simple words, it's the company that it keeps. When TERT meets BRAF, the tumor biology changes. Similarly, what are the indications for the germline testing? When the patient with differentiated thyroid cancer who have other associated tumors like breast, endometrial, or colon cancer, when there is DICER1 tumor predisposition, or there is a clinical suspicion of familial adenomatous polyposis. Other syndromes like Carney complex and Werner syndrome should be taken into the consideration. 882025 do not recommend routine germline testing for non-syndromic familial non-medullary thyroid cancer. The reason is the specific genetic variants found in these families are often private and are not supported by data for inclusion in the standard clinical panel test. So, what needs to be done for these patients? A careful neck examination should be part of regular health maintenance. Ultrasound screening can be done for the first degree family members who have 3 or more affected relatives. And the most important thing, the decision to screen should weigh the potential benefit of early detection against the risk of overtreatment. The optimal age to begin screening requires further study. Somatic testing is something like the mutation acquired by the tumor. They miss up to 8% of pathogenic germline variants because they do not diagnose the germline variants, small germline variants. They do not diagnose large rearrangement, and they do not assess inheritance pattern. So somatic testing is something like front door is locked, but you don't know what's happening inside the house. So 882025 emphasizes that even if somatic testing is negative, germline testing is to go to our model. So this slide may look dense, and so are the molecular panels also. And here, ATA applies the brakes here. It strongly recommends that pre-operative genomic testing is not recommended for surgery planning. It can decide the extent of surgery, but it cannot dictate it blindly. If genomic profile is available, then like BRAF's V600E and TERT promoter, it can be considered alongside clinical data. It has categorized our molecular risk categories like low risk, intermediate risk, and high risk, such as RAS and RAS-like mutations are low risk. BRAF-like alteration have been categorized into intermediate risk, and TERT promoters, TP53 and AKT1, they are the high risk mutation. So till now, we have been basking in the glory of molecular paneling, but technology can amplify skill, but it cannot replace it. Till now, ultrasound saves more life than the molecular panels. 882025 strongly recommends a preoperative neck ultrasound to detect central and lateral neck compartment for the gross extrathyroidal extension. Ultrasound-guided FNA for suspicious lymph node is a strong recommendation, with the loss of fatty hilum carrying the highest sensitivity and the lowest specificity. Along with the ultrasound, the role of preoperative CT or MRI of the neck and mediastinum is strongly recommended. It is an adjunct to the ultrasound for patients with clinical suspicion of advanced or invasive disease. It can help us delineate gross extrathyroidal extension, bulky or invasive lymph node, suspected involvement of windpipe or chest. Whereas ultrasound is more specific for nodal disease, CT and MRI are more sensitive for detecting nodal disease. 882025 do not recommend use of PET-CT for preoperative staging. Further, in the era of precision treatment, 882025 advocates for the active surveillance and the percutaneous ablation. Active surveillance is not doing something in action. It is disciplined care. It is recommended to select patient with a very low risk small papillary thyroid cancer. It has similar very low rate of all-cause mortality, distant metastasis, and recurrence. Whereas percutaneous ablation may be considered as an alternative to both active surveillance and surgery for T1A N0 M0 papillary thyroid cancer. But there are some limitations like less certainty of complete tumor eradication and no tissue sample for histopathological analysis. So after active surveillance, when to intervene? When there are biopsy-proven nodal metastases, when the tumor growth is greater than 3 mm, when there are distant metastases, extrathyroidal extension, posterior tumor progression, or there are patient-driven factors like anxiety and follow-up limitations. So 882025 guides the extent of surgery along the spread and the multifocality. If there is T1N0 M0, then the patient should opt for unilateral lobectomy. And if there is T1 multifocality, the patient should undergo bilateral total thyroidectomy. Similarly, in T2 stage, if there is multifocality, the patient should go for bilateral total thyroidectomy. In T3, T4, or N1 M1 involvement, total thyroidectomy is the preferred mode of surgery. This is AJCC TNM staging 8th edition, and this is some cumulative figures that have changed from 8th to 7th staging. I'm not going much into the details of this. 882025 have refined structural recurrence. This has been a 4-tiered system going from base to the top is the low risk to the high risk, and from green color to the red color, aggressive tumor biology. So this is a dynamic risk stratification system. Today's intermediate high-risk patient can be tomorrow's low-risk survivor as per the dynamic risk stratification protocols. So here comes our radioactive iodine, which bridges the gap between tumor and biology. In low risk, it is not recommended. There has been a paper from Professor Balser in the year 2023 where they have advocated that RIA versus no RIA offers no special advantage in the low-risk differentiated thyroid cancer. In the ATA guidelines, adjuvant RIA may be considered in the intermediate risk. In the high risk, it is recommended routinely. However, differentiated thyroid cancer with distant metastasis, it is recommended routinely after total thyroidectomy. So, our radioactive iodine has not become obsolete. We have become selective because appropriate use is the new precision. In the low risk, 30 to 50 millicurie, if indicated, is recommended. Intermediate risk, 30 to 100 millicurie. In the high risk, 100 to 150 millicurie. And for the distant metastasis, 100 to 200 millicurie is recommended. 882025 recommends that dosimetry is recommended for higher administered activities, especially for patients over 200 millicurie doses is to be administered. It is considered for older patients and those with a diffuse lung metastasis or renal failure. ATA have strongly advocated for the genomic profile. So if there are BRAF V600E and TERT promoters which have decreased iodine severity and less responsive to the therapy, they should be under the informed treatment choices. For the oncocytic thyroid cancer, there is no definitive recommendation. And for the patient preparation for radioactive iodine, I'm not going much into details because my dear friend, Dr. Vineet, will have an extensive talk on this. For the pulmonary micrometastasis and pulmonary macronodal metastasis, it has been recommended. And in the pulmonary micrometastasis, the treatment may be repeated if the disease remains iodine-avid and responds clinically. However, for the macronodular disease, the long-term benefit of radioactive iodine in these cases is not as high as with the micrometastasis, and the risk of side effect must be carefully considered. For the bone metastasis, consideration should be given to the combination treatment with a surgery or external beam radiotherapy. However, radioactive iodine is not generally curative for bone metastasis. It can offer significant clinical benefit and the palliation of pain. In the cases of TG positive and radioactive negative patients, in the patients with low stimulated TG less than 10 nanogram per ml with thyroid hormone withdrawal or less than 5 nanogram per ml with recombinant TSS, follow up with thyroid hormone alone is indicated. If persistent non-resectable disease is localized after empirical administration, the objective evidence of significant tumor reduction, then repeated radioactive iodine therapy can be considered until the tumor has been eradicated or tumor no longer responds to treatment. So, till now, our disease was listening to our language. When radioactive iodine treatment response do not respond, then we should change our strategy. Similarly, the cases with the radioactive iodine refractory cases, when there is no iodine uptake on the post-therapy scan, despite having confirmed disease on other imaging. Once a patient is confirmed to have a radioactive refractory, additional empirical radioactive iodine therapy is not recommended. Other treatment strategies need to be considered. What can be the strategies then? In the refractory cases, if there is progressive symptomatic disease, the tissue biomarker testing is a strong recommendation. If these are not available, then lenvatinib or sorafenib can be tried option. If asymptomatic, stable, and minimal progressive, the serial imaging every 3 to 12 months plus continued TSH suppression is the recommended protocol. So the first line therapy for multi-kinase inhibitor for radioactive refractory is the lenvatinib, and it should be initiated without any delay. And the dosing as per ATA guideline is 24 milligram OD. Other second line multi-kinase inhibitor therapy is cabozantinib. While other multi-kinase inhibitor like sunitinib and pazopanib have shown some activity, they are not FDA approved for refractory differentiated thyroid cancer and so are not preferred choices. Similarly, there have been targeted therapy for radioactive iodine refractory DTC, like for the NTRK fusion, larotrectinib, for RET fusion, selpercatinib, ALK fusion, crizotinib, BRAF V600E mutation lenvatinib, and if lenvatinib is contraindicated, then dabrafenib plus tramatinib is the recommended options. If the radioactive iodine refractory has oligometastatic disease, then focal ablative treatment is the treatment of choice. And if it is symptomatic, then the goal shift towards the palliative. So this is the response criteria after initial therapy based on the type of intervention. There has been some minor changes from the 2015, like the excellent and the intermediate, the TSH goal should be within the normal range, because it was found that in suppressed TSH, it was offering no clinical advantage even in low-risk patient on the indeterminate responders patient. And it was aggravating atrial fibrillation, osteoporosis, and the reduced quality of life. So after the surgery, total thyroidectomy, the serum thyroglobulin level should be measured at 6 to 12 weeks after surgery. Lobectomy, it has been recommended that it should be measured 6 to 12 weeks, but the clinical utility is limited as the remaining thyroid will secrete thyroglobulin. Single thyroglobulin is like a static. It does not give the clinical picture. So serial TG monitoring follow-up is recommended every 6 to 12 months. Follow-up we can do with the ultrasound, that is our primary surveillance tool, and the frequency is at 6 to 12 months post-surgery, and thereafter depends on the patient risk. Whole body scan can be done in intermediate high risk or high risk of recurrence when there is a clinical suspicion. When we cannot use whole body scan in lobectomy or an initial low risk total thyroidectomy patient without radioactive iodine treatment. SPECT-CT, if available, can be helpful because it can delineate precise localization of radioiodine uptake. FDG PET-CT can be used only at high risk of recurrence, especially if the patient have elevated TG level and the history of negative imaging. Specific subtypes like oncocytic, tall cell, hobnail, columnar cells, and other aggressive subtypes which have low iodine avidity but high metabolic activity, PET-CT can be used. A high PET uptake on the PET scan is a negative prognostic factor for response to the radioactive iodine. So in a nutshell, if I have to summarize what have been the changes from 2015 to 2025, in the overall approach, which was previously a static risk stratification model, it has shifted to new data framework. In the pathology, non-invasive follicular thyroid neoplasm with papillary-like nuclear feature is a new entrant. In the surgical management, when the previously for tumors greater than 1 centimeter and less than 4 centimeter, total thyroidectomy or lobectomy were considered. But now for tumors less than 2 centimeter without high-risk feature, lobectomy is now the preferred surgical technique. Previously in risk stratification, there was a 3-tier system like low, intermediate, and high, but it has been refined to 4-tier system like low, low to intermediate, intermediate to high, and high. About the RHEA dosing and the preparation, recombinant TSS is now the preferred method for the radioactive RHEA preparation in most patients. And the 882025 molecular testing for advanced disease, it strongly recommends tissue-based biomarker testing for progressive radioactive iodine refractory DTC. In the long-term monitoring, the 2025 ATA guideline provides a structured framework for de-escalation, including a clear definition of complete remission after 10 to 15 years, where routine monitoring can be continued, whereas in 2015, long-term follow-up for low-risk patients was open-ended. On this note, I would like to conclude with a slok from Sanskrit dedicated to my teachers over here. Yasya margdarshanen chikitsa vigyanam parishkritam tas shishya yugantaram chikitsa vahanti. Professor Bal, sir, you have been hundreds of nuclear medicine professionals of their understanding of thyroid and theranostics owing to the academic excellence and excellent mentorship of you. So on this day, we strive to seek your blessing to carry forward your rich legacy. Even thought of this is an honor, sir. Thank you.
Thank you, sir, for the lecture. We invite any questions and queries from the audience. We now proceed to a focused clinical talk on enhancing thyroid cancer care. We have amongst us Dr. Vineet Mishra, an alumnus of our department, consultant at Medanta Hospital, with 6 years of clinical experience and multiple publications to his name. Dr. Mishra will discuss the role of recombinant human TSH in optimizing radioiodine therapy.
Sir, may I request you to begin your presentation?
Respected teachers, delegates, and dear colleagues, good afternoon. So I'll start my talk with a few patients we encountered recently. Mr. A is a 43-year-old male, engineer in UAE, and he total thyroidectomy for the radioactive iodine therapy. He has limitation that he cannot stay for a long time in India, so he needs this therapy to get it done, and he also do not want to get any hypothyroid symptom due to his job. Mr. B is 82 years old gentleman. He is a known case of Parkinson's disease for quite a decade, and he was treated for the follicular carcinoma of thyroid back in 2012. And later on, pointer. Sorry. So he developed a recurrence in nodal recurrence in 2025, for which first time he was treated with radioiodine therapy with the thyroid hormone withdrawal method. After this, he developed metabolic encephalopathy, which was by investigation ruled out to be due to the hyponatremia. Now he again came for the treatment response evaluation. Third patient is Miss C. She is a 20-year-old female, a college-going student, and after total thyroidectomy and CCLND and lateral lymph node dissection, she came to us for this radioactive iodine therapy. And on HRCT test, she had extensive macronodular lung lesions. And finally, Mr. D is a 79-year-old gentleman, teacher by profession. He had a history of chronic kidney disease, and for the last 5 years, And after total thyroidectomy, he came to us for radioactive iodine therapy. So the common question in all of them were how we should proceed for the preparation of radioactive iodine therapy. Should we go with the usual thyroid hormone withdrawal method, or should we go with this thyrogen or recombinant hormone or human TSH method? So what is this recombinant human TSH? Recombinant human TSH is a genetically engineered TSH produced by inducing the Chinese hamster ovary cells. And these have the identical amino acid sequences as the TSH produced in the pituitary gland. Although it is comprised of both alpha and beta chains, it is still named as thyrotropin alpha. So the main difference arises during the glycosylation process. In the glycosylation process of this native pituitary, this ends in sulfated N-acetyl galactosamine residues. But since these Chinese hamster ovaries cannot produce enzyme for this complex glucose, so they end in the sialic acid. This sialic acid masks the molecular expression for the hepatic clearance. Normal TSH gets cleared from the liver and generally have a shorter half-life. This RSTSH generally have a longer half-life, approximately 22 to 25 hours. And this is due to this change in the glycosylation only. After the injection of this thyrogen or recombinant human TSH, it is injected via intramuscular route, and it is slowly absorbed in the bloodstream and having a Tmax approximately 10 hours. After which it achieve a peak concentration. After a single dose, it achieves a peak concentration approximately 160 millunit per liter. And the standard protocol is 2 doses 24 hours apart, which creates an stacking effect and a longer half-life for this RSTSH. And since, as we have already discussed, that it is not excreted through the liver, it is excreted through the kidneys and having a higher half-life. One thing is to be noticed that in cases of end-stage renal disease, the clearance would be slower, obviously. So that is one thing we should always think about. So what happens after if we give only one injection or if we give 2 injections of this recombinant human TSH? After the first injection, the blood concentration of this TSH reaches at its peak approximately 10 to 13 hours. And then it lowers down slowly. In approximately 24 hours, its blood level halves. And then almost in the 125 hours, that is approximately 5 days, it gets eliminated from the body totally. In case of the standard protocol, which is 2 doses, 24 hours apart, first after the first peak, when the second dose is given after 24 hours, it reaches another peak and then decreases down slowly, giving us a time of more than a week for this further treatment. What does this RSTSH do to our body? That is the pharmacodynamics. So normally this RSTSH is binds to TSH receptors present on the well-differentiated thyroid cells, whether it is cancer or normal cells, and they amplify the signal, resulting in the transcriptional activation of critical thyroid gene. This activation first upregulates the sodium iodide importer and causes its expression on the thyroid cells. Then it activates the TPO, thyroid peroxidase, and it promotes the thyroglobulin synthesis and release. This thyroglobulin production starts approximately 3 to 24 hours after injection, and this peak level is achieved after approximately 72 hours of final thyroid injection. So the ideal time when this thyroglobulin should be estimated is approximately 72 hours after the final thyroglobulin injection. So what is the utility of this RSTSH? Why should we give it? So first is for the diagnostic utility. To know the stimulated thyroglobulin level. Normally, in the physiological state, TSH level, low TSH minimizes the thyroglobulin secretion, and that's why the sensitivity for the detection of the residual disease is lower. TSH, RSTSH or by withdrawal method, increased TSH increases the thyroglobulin production and release, and its primary utility is the confirming the no evidence of diseases, and it has obviously has higher sensitivity, and there are reported cases in which it can detect occult diseases in which suppressed TSH is undetectable. However, if we talk about the specificity, rising serum suppressed thyroglobulin has a very strong predictor of the disease recurrence. Wherever this stimulated thyroglobulin is very strong predictor of negative predictive value of the disease. So current paradigm is suppressed TG is often sufficient to rule out diseases in low risk patient, but in case of indeterminate response or in biochemical incomplete response, stimulated thyroglobulin should be sought for. Then comes another entity of patient who have positive anti-thyroglobulin antibodies. In these patients, thyroglobulin is unreliable, and just switching from the thyroid hormone withdrawal method or RSTSH or any other method does not fix this thyroglobulin antibody interference. So in these patients, role of RSTSH is predominantly to stimulate uptake for the whole body scan, and this whole body scan and neck ultrasound remains the mainstay of monitoring for these patients. In the point of view of whole body iodine 131 scan, there has been multiple studies comparing both RSTSH method or thyroid hormone withdrawal method, and almost all the studies were showing that they were similar or comparable in sensitivity for the disease. So when we compare RSTSH and thyroid hormone withdrawal method regarding their diagnostics and whole body scan, sensitivity is equivalent in both the way. However, there is a theoretical high sensitivity in low-activity bone lesion in some reports. Image quality is higher in RSTSH because the thyroid hormone withdrawal method decreases the GFR. This decreased GFR causes a bit of more retention of the radioactivity in the bone body. Also, there could be a bit more background uptake. Same thing happens with the radiation safety. So effective half-life of iodine 131 is lesser in case of the RSTSH thyrogen method, and it is more in case of the normal thyroid hormone withdrawal method. Since its duration in the body, its residence time in the body is lower, the stunning effect is lesser in case of the RSTSH and more in case of the thyroid hormone withdrawal if there is some gap between the scanning and therapy. From the diagnostics, we come to therapeutic applications. So this therapeutic application came from these two landmark studies. First is HALO study, second is STMBL studies. Both were published in 2012. And key findings of both studies were that RSTSH was non-inferior to the thyroid hormone withdrawal method. But there is significant better quality of life in RSTSH method. And even for 5-year recurrence date were identical in both the groups. However, RSTSH group has lower whole body radiation retention due to the faster renal clearance. Most of the patient in these two trials were of low risk category thyroid cancer patient. Later on, previous the ATA intermediate risk group, in the intermediate risk group, there were a few analyses like thyroid node cohort, clean has link, and Castagna cohort. In all these studies, main RSTSH and thyroid hormone withdrawal method were having the seminal fire status and disease-specific mortality. And there is no difference in the persistence of disease mortality in either group. And there was not any significant outcome difference in either group. Then there were few recent trials in the high risk. These are the retrospective studies only. In all these studies, RSTSH group is similar to the thyroid hormone withdrawal group, and there were no significant changes in outcome in both the groups. So after that, we come to the comparative dosimetry of both the methods. Since thyroid hormone withdrawal causes hypothyroidism reduces the GFR. So there is a reduction of renal blood flow by approximately 50% in cases of the thyroid hormone withdrawal method. So this leads to a greater retention time, and RSTSL leads to a lesser whole body retention of the iodine. This salivary gland uptake depends on the blood iodine level only, and not on and it is not NIS dependent. So a faster renal blood clearance means lesser salivary exposure, so better salivary protection in cases of the RSTSH. And similarly, the lesser retention time in blood, so lesser bone marrow retention of this iodine 131. So RSTSH allows for a higher administered activity before this marrow safety, that is of approximately 2 gray, is reached. How we do administer this thyrogen? This is for the radioiodine ablation. First thing that we should know that these two vials of the RSTSS, that is thyrogen, which come in lyophilized form. We have to add 1.2 ml of sterile water, not the normal saline. First thing. Second thing, withdraw only 1.0 ml, not the whole amount of solution. The whole solution would be approximately 1.3 to 1.4 ml after the reconstitution. But if we have to withdraw only 1.0 ml, that is equal to the 0.9 mg of thyrotropin alpha. Then 2 injections 24 hours apart in the gluteal regions. In case of necessity or if required, this reconstituted solution can be kept up for 24 hours up to at a temperature of 2 to 8 degrees Celsius. So for this radioiodine ablation, first we give thyrogen 0.9 mg on day 1, then 24 hours apart on day 2, and then we give radioactive iodine for the ablative dose. For the diagnostic evaluation, same. First day we give thyrogen, second day after 24 hours we will inject thyrogen, and then after 72 hours, because the maximum thyroglobulin level would be after 72 hours of the last injection. So blood sampling should be done on the day 5, not the day 3. Another thing is, if we are planning for whole body scan, then after the 2 injections, diagnostic dose should be administered on the day 3, and on the day 5 we can do scan as well as thyroglobulin for the blood level measurement. And that was the case in case of general population. Then there are people with who have some comorbidities or in special population, like in renal failure. In case of renal failure, the thyroid hormone withdrawal decreases the GFR even more, and also results in the toxic marrow dose. So RSTSH method preserves renal clearance and reduces marrow toxicity. In case of cardiac patients, hypothyroidism could lead to the fluid overload, which can be prevented with the RSTSH method. In case of pediatric patient, since RSTSH gives a lesser marrow radiation, there could be a long-term benefit for the child. Now, 2 special scenarios. First is hypopituitarism, in which a person cannot produce enough TSH to raise significantly. In that case, RSTSH or thyrogen remains the only way to get the elevated level of TSH. Also, in case of functional metastasis, tumor suppression causes the negative feedback loop, and TSH never rises by the withdrawal method only. In that cases also RS-TSH is the only beneficial thing. But this RS-TSH is not it's a very safe drug, but there are some conditions in which we have to be cautious. First thing, what are the common adverse reactions? The most common is nausea and headache. Not a big issue, you can easily manage it. Then fatigue, not an issue, you can easily manage it. Then if a patient is having brain or spinal metastasis, this sudden rise of TSH may increase the size of the tumor. So you have to early start the high dose of steroid in these cases to prevent this increase in size of the lesion. Then in case of functional metastasis, TSH production may T3 T4 production may increase due to the high TSH level. So in these cases, always be cautious to use beta blocker and careful hemodynamic monitoring. If there is bulky tracheal disease, TSH may cause increase in the size of the mass. So always use steroid before the RS-TSH. Graves' arboretopathy is a in case of Graves' arboretopathy, RS-TSH is a beneficial thing. RS-TSH is safer as prolonged hypothyroidism may increase to eye disease, which would be lesser in case of RS-TSH method. So what does the current guidelines say? For remnant ablation, RS-TSH is standard or preferred by both ATA 2025 guideline and NCCN version 1 2025. For adjuvant therapy, RS-TSH is preferred in ATA 2025 guidelines and ETA 2022 guidelines. For metastatic therapy, according to NCCN version 1 2025, RS-TSH is an accepted alternative. For diagnostic whole body scan, RS-TSH is standard, and even RS-TSH can be used in oncocytic carcinoma of thyroid for the staging according to ATA 2025. After this conventional thyroid hormone withdrawal, there is another thyroid hormone withdrawal method, that is T3 protocol, in which for the first couple of weeks, patient is shifted from T4 to T3, and then after a couple, T3 is initiated for approximately 2 weeks, and then in both cases, ablation efficacy is equivocal, and renal safety is better in RS-TSH method. In case of redifferentiation protocol, RS-TSH is preferred because you can timely elevate the RS-TSH depending upon the requirement. So finally, which patient went which way? First patient, the engineer who wanted to get it done early so he can return to his job, and he did not wanted hypothyroid symptom. We went with RS-TSH method. Mr. V, who has last history of metabolic encephalopathy and hyponatremia, also went with RS-TSH method. Third, Miss C, which have extensive macronodal lung metastasis, we went with thyroid hormone withdrawal. And fourth, Mr. D, who have CKD, we went with RS-TSH method. In the conclusion, RS-TSH in DTC has shifted from the convenience option to the preferred standard of care, and it decoupled from this hypothyroid symptom from this radioiodine therapy. And now it is established standard in lower intermediate risk. It is also getting frontier in the high risk and metastatic disease, and it is also enabler in the advanced protocol like redifferentiation therapies. Thank you for patient listening.
Thank you, sir, for the informative lecture. We now invite any queries from the audience.
I just no query. I just want to comment that in Vinith must have seen. There is a recently a publication in GM which shows that the observed dose, there is no difference in the remnant with RS-TSH and thyroid hormone. Yes, and there is a difference in the metastatic one. Yes, that's right. Thank you.
Thank you, sir. Ladies and gentlemen, we now come to the highlight of today's symposium, the Professor B.K. Das Memorial Oration. This oration honors the legacy of Professor B.K. Das, a visionary who laid the foundation of nuclear medicine in India. It is a privilege to have Professor C.S. Bal deliver this prestigious oration. May I request Professor P.K. Pradhan to introduce our esteemed orator.
कहाँ है तुम्हारा?
ऐसा ओरिएंटेशन
Good afternoon to all of you. I think this is the time when we should remember late Professor B.K. Das, who was established with his leadership in the Department of Nuclear Medicine here. I think he also is a great visionary who showed the path of education to this country in nuclear medicine. I think it is also very important that I am privileged because we are, I was a junior resident along with Professor Bal. So it's my proud privilege to invite him. And also he's a real visionary leader transforming the global cancer care. I think he did his, he born in Orissa in 22nd October 1960. And subsequently, he did his schooling and there in Orissa from a Oriya school. And later on, he graduated his medical school from SCV Medical College, Cuttack. And then subsequently, he came to All India Institute to do the biophysics. And subsequently, he progressed through all academic ranks to professor and head. And recently, he retired as a dean along with his professor and headship in the Department of Nuclear Medicine. And he is also awarded the DSC for outstanding scientific contributions. I think Dr. Bal has many laurels. He has 53 pages of his biodata given to me. I think to summarize this, it will take another, 50 minutes. And I have many things to say about Dr. Bal, but I think with the limitations of time, I will not go through. But nevertheless, I think we must, because transforming thyroid cancer management, all you know, he has 3 points only I will tell regarding the remnant ablations of 30 millicurie, which he did as a investigator trial, but subsequently with your STMB trial and your high-low trial, it has been proven because the most of the Western people who are doubting about this concept, I think that concept really became true after 15 years of his publications in cancer. And this was really remarkable, and it was incorporated into ATA guidelines in 2015. I think we have expanding evidence of thyroid cancer. He pioneered also the radioiodine ablations. I think Dr. Bala, I have seen 2 publications, another from Harvard, and you have almost more than 500 patients doing lobar ablations, and a major contribution also to the pediatric differentiated thyroid cancer. I think 5 studies, publications cited in American Thyroid Association about pediatric DTC guideline in 2015, and the landmark paper in the Journal of Clinical Endocrinology and Metabolism in 2024 study proposing the cumulative activity to be 1,000 millicurie with respect to the Western countries of ATA of 600 millicurie in metastatic thyroid cancers. And the number of thyroid cancers which has been analyzed, this is the highest in the world. And the leadership, I think in every conference now, wherever I listen, I think the most important, if you talk of alpha therapy, that means it is Professor Bal. Many of the global experts, when they meet me, sometimes they ask, do you know this guy who is doing alpha therapy in India? I told he's a good friend of mine and a senior colleague of mine, and we grew together. But at the same time, I say very proudly that India is the leader of alpha therapy with the visionary leadership of Professor Bal, and first to initiate a 225 actinium PSMA 617 therapy in a government institution in India, All India Institute, and advanced management of metastatic castrate-resistant prostate cancer. That really positioned India at the forefront of targeted alpha therapy research. Whenever I listen now to any talk, I think always these three papers came. The first author is Sanjana Balal, her PhD student, and Madhav Prasad Yadav, another PhD student. He had 6 PhD students into his, who guided by him only, and a lot of MD and DM student, which I'll come later on. And this has been in the cover page of Journal of Nuclear Medicine. And theranostic and radiopharmaceutical innovation, I think, are extensive work in radiopharmaceutical development and clinical translation. He's a co-inventor of a fibroblast protein inhibitor and fast globally radiolabel FAP inhibitors with gallium, lutetium, and also 225 actinium. And this has been basically his collaborator is Professor Frank Rose from University of Mainz, the chemistry division. And the clinical applications has now extended beyond thyroid cancer to the breast cancer, sarcoma, and glioblastoma, who has several publications in this area. Coming to the research productivity and scientific impact, I think 600 plus peer-reviewed publications, which are indexed 543 index PubMed, and you can see the citation metrics. The H index is 56 and I-10 index is 268. Over 12,000 total citations he has. Editor-in-chief of Indian Journal of Nuclear Medicine. I think he has really shown the path of theranostics to the world, and also he really, now the world is talking of education in theranostics. And now I think 10 years back, I knew very closely that 80 years he tried to really make them convinced to the All India Institute of Medical Science, Staff Council, all these committees to make a DM program. Nobody was listening for 80 years. And we began in 2015. That means he has already thought of in 2000, almost 7 or 8. And later on in 2015, this was started in the All India Institute. And now the world is talking about education in the theranostics. And he was also chairman Nuclear Medicine Curriculum Committee of our NMC, which is currently there, earlier MCI, I think since long. And he also standardized training in radionuclide therapy, dosimetry, and theranostics. Both are evident from his publications. If you look to the dosimetry of thyroid cancers, neuroendocrine cancers, and everything. And now he has mentored 6 students, I told, and many students of AMD and PhD in the country. I think he's very popular as an educationalist, as a teacher, and a postdoctoral trainees globally. The global contribution and honors, he is a senior IAEA expert for nuclear medicine capacity building. I saw his biodata. He has traveled to almost all the countries of Africa for almost 10 years. To just teach them to improve the nuclear medicine through IAEA. And he's a member of the International Committee defining radioiodine refractory DTC. He is the only member from India in the ATA where for the defining the radioiodine refractory DTC, and he's all the science award, whatever is possible, he has acquired. That is a fellowship, fellow of INSA, Indian National Science Academy, IASC, this is from Bangalore, and NMS, and he's a SNMMI Best Researcher Award of USA. And I think he also bagged the European Award recently in 24-25. I think there is no award which is really lagged behind by Dr. Bal. I wish that he will have more awards in the future, and his legacy and vision will continue, exemplifies bench to bedside translational research, changed international guidelines and clinical practice across the globe, and pioneered theranostic and alpha therapy in India, continuing to shape precision oncology worldwide. Thank you, Dr. Bal. Now it's a time for you to really speak to us.
Thank you, Dr. Pradhan, for your flowery language, but I don't deserve that much. But I am a grassroots worker. I always believe we all publish for getting our promotions. You know, if you are working in a government institution, if you don't have 4 publications, you cannot be assistant professor. You can, if you don't have 6 publications, you cannot be associate professor. 8 publications for additional professor, and 10 publications for professors. And there are a lot of people who are trying to make it in no publication. Of course, in new aims, they are trying to having no publication for promotions. That's okay. That's fine. But I say, if you will see, if the Watson and Crick got Nobel Prize, Dr. Watson and Crick got Nobel Prize in discovering the alpha helix of DNA, and that paper was only 1 column and half column. In Nature, there are 3 columns, and the paper published by Watson and Crick was only 1.5 column, and that leads to the genetics, and that leads to the Nobel Prize for them. So it is not the how many papers you publish. If any work you do that can change the practice, that is most important. For publication, for our improving CV, we publish. But that if that publication leads to change in the management, not only in your institution, in your country, globally, that gives a lot of satisfaction. That is what I always encourage. Publication are byproduct of your research work, not the aim of doing. I must get published. I must get published. That's not. You're just sharing your experience with others, because others will learn from that work. They do not do the same. They do not repeat the same mistake what you did earlier. So what I'm going to, in this brief time, to say 3.5 decades in academia, path to excellence. So I was all the time interested in, you must do clinical research, because bench side research is done by Dr. Manish Dikshit. But you won't convert that bench into bedside. That is the aim of a clinician scientist. If you are a clinician scientist, because many a time scientists don't understand what we need, and many a time clinicians do not know how to develop that molecule. So if they can work in tandem, they can work as the collaborators. I think that is, and I will show you how the collaboration from a chemistry department from Frankfurt has changed the globally, and it has given something new to the world. So coming to the Professor Das was like my mentor. In first time I came to Sanjay Gandhi. Sanjay Gandhi is like my second home all the time. Even last month I was here. So Sanjay Gandhi is my. Dr. Das convinced me to come to join as a faculty at Sanjay Gandhi. Unfortunately, I was selected, but I could not join. And then in '89, Dr. Das created the department in '88. And in '89, he was holding the national conference. And for the first time as a nuclear medicine physician, I attended this meeting in the Sanjay Gandhi. That's why I had an interaction with Dr. Das and Mrs. Das from that day. See, he was definitely a doyen of nuclear medicine. He was a visionary. And most importantly, he was an institute builder. And his thinking is always big. And you know, there is when Dr. Das came to Shere Kashmir, he was the only doctor in that institution who had 2 Benz Mercedes car in Shere Kashmir, which he got it directly from the Germany. So he was born in a small town in Odisha, but he got his medical education in Frankfurt. He got his schooling there in Göttingen. Then he got his graduation from the Berlin, and in radiation science and nuclear medicine from Frankfurt. He reached to the position of associate chief of nuclear medicine, and in a 1,200 bedded hospital in Frankfurt, University Hospital, that's called. In '82, he applied to Shere Kashmir, was just created, and he wanted to move from Germany to India. Because in Germany, you cannot be chief because you are not a German. So, so he wanted to come to India to serve his country. And at the very ripe age of 40 years, he applied for assistant professor in Shere Kashmir. And Dr. Sneha Bhargava was the director of All India Institute and also the chairman of the selection committee in Shere Kashmir. When she saw the biodata of Dr. Das, He had already publication in seminars in nuclear medicine and other things. She told, you are overqualified for assistant professor. We are making you the professor and head. So that is how Dr. Das, at the age of 40, became professor and head at Sere-Kashmir. And that was 1982. And he created Dr. Das always created a big thing, always. He had a big picture always. He had 6 senior residents in Sere-Kashmir when All India Institute had only 1 senior resident. And in Radiation Medicine Center, RMO, only 1 RMO. So Dr. Das created 6 senior resident posts, then 4 faculty members, Dr. Savatkar, Dr. Jahangir, and a lot of people were working. Now big names in nuclear medicine all are trained with Dr. Das in Sere-Kashmir. Because of that, that is the initial part, there was some problem just starting. Then Dr. Das wanted to come out of Kashmir. A lot of people from Sere-Kashmir moved to SGPGI because SGPGI was just opening up. In 1987, Dr. Das joined and he created his department in 88. And he was, if Dr. Das will be, and he rose to the level of become the dean of this prestigious institute. If Dr. Das will ever remembered for anything he has contributed to this country, is the starting the AMD program in nuclear medicine, first time in this prestigious institution. So Sanjay Gandhi name will be always written in the golden word that Sanjay Gandhi started the first AMD program. It will be interesting to know that in 90, the people who are talking that so can nuclear medicine survive the turn of the century? Because it will not be. But he had a visionary. He wanted to start, and there was not PGI, not AIMS, not RMC, not INMAS. It was Sanjay Gandhi who started this. So Dr. Das will be seminally remembered for that contribution which he had made. And he has been honored by FMS. Then he was the Dean of Indian College of Nuclear Medicine. He achieved Lifetime Awards. And his most prestigious, he has given several orations. The most prestigious oration was Bikram Sarabhai oration by the Society of Nuclear Medicine. He had published 155 papers and 6 books, and he has written books on many things, not only nuclear medicine and cancer. He was the first medical director of Rajiv Gandhi Cancer Institute. So he had created Sere-Kashmir, he has created SGPGI, he has created Rajiv Gandhi Cancer Institute, and many more to come, I will say. Then he was superannuated and he went to the Science University of Malaysia. They call SIAM and something like in Malaysian town. This is the Science University of Malaysia. He was there for many years. He started the nuclear medicine program. And in 2007, he wanted to come back to Odisha. And I'd say in the eastern part, the nuclear medicine is the poorest. And he, in that area, he started PET CT in a no profit, no loss basis. It's a daring step for him. He started and it grew very well. And then subsequently, he, with the help of other collaborators, he started an institute called Utkal Institute of Medical Sciences. And till his final journey, he was nurturing that institute. So this is Dr. Das, and ever remembered in this country. So my talk will be on thyroid cancer. And many discussion has already occurred. I will go first. Then we'll talk about the birth of new era and the theranostics. And then finally, not the last, but the most important thing is alpha-cuticles. The radiopharmaceutical attached to the alpha is called alpha-cuticles. So after completing my residency in Radiation Medicine Center, I joined as SR in nuclear medicine on 1st January 1990. Another 5 days, I will complete how many years you can calculate. So 36 years. So it will be, I was asked, Dr. Padhi asked me that you look after the thyroid cancer clinic. In that time, our Radiation Medicine Center had 2,000 patients and All India Institute had only 204 patients. So he told, okay, that thyroid cancer, nothing will be done from AIMS. So he was given to the Dr. Bal. So he doesn't know that he was handing over a gold mine to me. So he was thinking it is garbage, but actually he was handing me the gold mine. So the waiting list, when he gave me a diary, the waiting list was 18 months. And when the patient was recently operated, he will be in the highest level of anxiety. I have got cancer. As many hours you spend on explaining thyroid cancer is very nice. Billion Love says it is the best cancer to happen, but the patient will be always anxious. So how can I reduce the wait time and still scientifically sound? Who has given this? In radiation medicine center, they used to give 200 to 300 millicurie. And I asked Dr. Sharma, where you got this 200, 300 millicurie concept? Then I looked, that is the culprit is William Beer-Waltis, who is considered the father of thyroid cancer, University of Michigan, Ann Arbor. So he thought, if you give 200 and 300 millicurie, the circulating tumor cell from thyroid cancer will get killed, so the recurrence rate will be less. And this, is it evidence-based? I asked, mostly in medical science, it is evidence-based, not evidence. If a professor from Harvard University says this is right, everybody says, oh, this is right. So this is called eminence-based, not evidence-based. So is this evidence-based? To answer this question, we need a class 1 evidence. So that is randomized control trial. But unfortunately, in aphorism, in nuclear medicine and in endocrinology and in US and even in India, you cannot have a randomized control trial in thyroid cancer because the number of cases is so low. In 1990, I convinced the Institute Review Board to conduct first randomized control trial. And it took me 5 years to recruit only 149 patients, 5 years to recruit. And then in 1995 summer, I presented in the Minneapolis meeting, SNM. It was an oral presentation when I was just very young, assistant professor. And I spent 6 weeks with Joe Mantle in catering, and that time I got full time. So I wrote the paper, submitted to the cancer, not to the nuclear medicine journal, because in US, the thyroid cancer is managed by the endocrinologist and they don't read nuclear medicine journal. So I thought I should publish in cancer journal. And that time there was no JCO, there was no Lancet Oncology. It was Cancer, which was the #1 journal in that time. So I sent it, and 6 weeks later, the paper got published in cancer. And that is the first randomized control trial ever published in the field of thyroid cancer. And the guy who helped me is Dr. Suman Jaina. He was one of my resident, and he compiled the data, and he is now professor of endocrinology in University of Cincinnati. And recently he wanted to move to nuclear medicine also. So what is the importance of this work? This work for the first time demonstrated, if you give more activity than 50 millicurie, the dose response curve becomes flat. So nobody has ever shown. So they have shown, okay, you will give tumor cell circulating number. Who has seen in 1990 tumor circulating cell? Nobody. It is a hypothesis there. So we found that 30 to 50 millicurie, what we are now 2025 guideline says, you give 30 to 50 millicurie. We know since 95. So after 50 millicurie, the dose response curve becomes flat. You can see the highest achievement ablation is 78%. Then it becomes 77, 76. But the radiation dose to the patient increases exponentially, and your marrow dose becomes very high. It may exceed 2 gray blood dose. That is the limit. That's why first time we demonstrated that if you give higher dose, you are doing more harm to the patient, or you are adding more days, hospital days to the patient. If you give 200 millicurie, the patient has to be whole week. Patient will have more gastritis, patient will have more symptoms. And then the cost of iodine, and then hospital admission, and most importantly, it is going to the environment. So the AERB people will be on your up to your neck that you are discharging patient with a lot of radiation. So all these economic ground, health ground, and radiation safety ground, this was a seminal work for the first time demonstrated. And then we published this paper. There was a question from the Karolinska Institute. Professor Randall wrote a letter to the editor to the cancer that Dr. Bal has shown the upper limit should be 50, but he has not shown what is the lower limit. It is 5 millicurie, 10 millicurie, 15 millicurie. What is the lower limit? We don't know. So I wrote in the response to the letter to editor that we are going to do another trial, and this time I was more popular. So I did this trial in 5 years, again 5 years time, but this time 509 patients, and published in Journal of Clinical Endocrinology and Metabolism, which all the endocrinologists read. So this becomes the seminal work, showing that anything more than 30 millicurie to 50 millicurie, same response. So which now they have adopted 30 to 50 millicurie. This was done by Dr. Ajay Kumar, who is now faculty in UPenn, University of Pennsylvania. He was my MD and PhD student. He was my first PhD student. So in 2005, after this publication in 2004 in JCM, the Endocrine Society brought out, they call three perspectives. They will ask a clinical, to a basic scientist, which is Jem Hajin, which is from Memorial Sloan Kettering, and Arni Majaferi, which is called father of thyroid cancer, which is a clinical scientist, and the Mike Tottle. Now everybody read any ATA guideline, Tottle name will be there. So he's from Memorial Sloan Kettering. These three people are asked to write, only choose 12 papers which has really changed the management of thyroid cancer. And you will find all three of them, basic scientists, clinical clinician, all of them found that our work, 2 papers published that in Cancer and JCM was cited by all of them. This is a practice-changing publications. And then in 2013, Cheng published a meta-analysis on this remnant ablation. There are small publications. Finally, there was 2 national trials. One is HILO trial in UK, 450 patients, and estimable trial, 700 plus patients by Dr. Schlumberger, and all confirmed. What they added is only recombinant TSH. We had no access to recombinant TSH. It's very expensive for us, $1,100. So they got recombinant TSH from the company. They got it free, so it's okay. What we found that 30 millicurie or 100 millicurie is identical, and all this, and then meta-analysis. Once a meta-analysis confirmed all this, out of 10 papers, 3 papers is from my group. And then 2000, finally, the ultimate day, and my satisfaction, the ATA recommended that 30 millicurie is sufficient. There is no need of giving 200 millicurie. Then, this is my first patient, who was a school teacher from Bihar, was operated by a very eminent surgeon, who is now the current head of the department at AIMS. And he, because of the aberrant recurrent laryngeal nerve, he cut the nerve. So the patient became hoarse. And she's a teacher. If you try to do the other side, if the nerve is aberrant, then she will be whole lifelong on permanent tracheostomy, and the profession is gone. So he requested me, can you do something with iodine? I don't want to operate this lady. I looked into the literature. Everybody is so damn scared. They say the sky is going to fall if you give radioiodine, and there will be radiation thyroiditis and all this. I told, okay, I will give 30 to 50 millicurie, let's see. And 6 months later, you can see the right-hand side, everything is gone. So he sits on, his OPD was in 5th floor and mine is ground. I ran with the patient on the scan. I said, it is done. He told, let's do more work. So now we have more than 1,500 patients which we have given, not sent for second surgery, we have given radioactive iodine. So then we did this first publication with Greg Randall from the Mass General Hospital, MGH, and Harvard University, and our identical paper. Only they took the follicular thyroid cancer. We took follicular and papillary and demonstrated that it is feasible. You can ablate. Success rate is identical. And then we wanted to do a long-term outcome. This time we wanted to outsmart the Harvard. So we published our first paper showing on 700 odd patients, we have 372 patients on completion thyroidectomy, 364 patients with RILA. That is called radioiodine lobe ablation. This term is coined by me, called RILA. So this is radioiodine lower ablation. And you can see the identical result, 1.8% recurrence versus 3.8%, statistically not significant. So this has again led to the recommendation 2015 that it may be used ablate the remnant lobe in selected cases. And then there was a big paper published in JACS, that is Journal of American Cancer Society. 32,000 patients followed up from SEER data. 24% of them were given lobe ablation. They found exactly same what we are talking. Then recently we did a propensity, in the absence of randomized control trial, the best, the quasi-RCT is called propensity matched analysis. And we did a propensity matched analysis in our study, published in Thyroid. This is the showing that 512 patients, 514 had RILA, 729 patients underwent 2-step surgery followed by iodine, and the results are identical. With 10 years follow-up, the recurrence rate is 1.6% versus 1%. So this is what the surgeons are doing with their knife. You can do with radiation knife, unseen knife, I always say that. So coming to the new era, alpha-cuticles and our work in this field, it gives me immense pleasure to talk because it's very sentimental attachment to me. This is the first work done from Heidelberg University. Katochil used actinium. This is bismuth 213. Bismuth 213 is daughter product of actinium, but it has got unfortunately half-life only 46 minutes. So they wanted to deliver directly into the hepatic artery, assuming that if it is closure, it will take more. But you forget that anything you put into the artery or vein, it will be, if it is a molecule, it will go immediately equilibrate. So unnecessary you are doing injuring to the femoral vessel, going to the selective cannulation hepatic artery, going super selective to the tumor. It's all costs and there is no reason. If you understand science, you will never do that. Anything you put into the artery or vein, into the circulation, immediately it will equilibrate. What they do in tests, after giving chemotherapy, they block with the foams. So they block, then only it will not go. Because the tumors, they get the supply from the hepatic artery. And if you block, then there will be no recirculation. That's what they forgotten. They keep, but they got good result. So that's why, but unfortunately, since that this was published in 2014 and 12 years has passed, nobody has done any other study because it doesn't justify. What I did, I thought, if you are going to use bismuth, why don't you use my nano generator, actinium, the mother of, great grandmother of bismuth. So is the actinium 225. And fortunately, we got some funding from the ICMR. That is my largest fund from 1.5 CR. I got from the ICMR to do this trial. And this was the first test case. So this is a 54-year-old primary tumor, ileal net, extensive liver metastasis, stable dose. After 6 cycles, we could not achieve complete remission. And then actinium dotatate 2 cycle, you can see the tumor is gone. So then, getting excited with this, we wanted to get the ARB approval. And then Sanjana did the, Sanjana is my PhD student at the time. So we give her projects. This is the broadening horizon of actinium dotatate targeted alpha therapy in neuroendocrine. These are preliminary data on 23 patients. And then this paper has till date cited 225 times in last 5 years, 225 times. Any paper, anything written on actinium dotatate, they cite this work. This is the how you can see this patient who had extensive meds after lutetium failed. Then you can get near complete or partial, very good partial response we achieve. And then we have now 91 patient data we presented in SNM. And then it was the showing 24-month progression-free survival was 68%, 24-month overall survival was 71%. And the significant benefit was achieved with actinium dotatate therapy with minimal treatment-related toxicity. In the right-hand side, there is an interesting point. There are patients who had progressed on lutetium Lutathera, but they are given actinium as a treatment to prolong their life. And then people who had stable or partial response on Lutathera and then given actinium. In the third category, those upfront, who told you just like your recombinant AS engineer told you, give me recombinant AS, I don't want to. We have several patients like that. They okay, we want to take actinium, we don't want to take lutetium and then actinium. We expected those people who are given actinium dotatate directly, they will do better, definitely. But interesting, we found in between. Those who are given lutetium dotatate and remain partial or stable, they did better than those who are given upfront. Because what I say, what is the explanation? When you give lutetium dotatate, so you are separating the apples from the oranges. The people who are progressing, we want to prolong their life. So you give them actinium, so you prolong their life. People who are stable on Lutathera, they remain stable after actinium. So you can see the first line is going parallel. And the in-between comes. Now, actinium separates which are responding, which are not responding. So this is the hypothesis here. And this was the paper. You can see this, the paper which came in the cover page. This was a featured article and featured image of the month. And then this was published on JNM. And then we have got, after that, this was when it was published in 2023, it was 2023. And after 2 years now, in 2025, before I superannuation, I called the patient. I wanted to see what is its status. And it's still disease-free. So now, 2018, 2025, 7 years is disease-free. He was only 35 years with extensive liver. You can see, don't see any space in the liver. He's now disease-free and 7 years. I don't know, maybe in future, my juniors will pick up the recurrence. Definitely will recur on one day, but at least 7 years given good life. So this is 2021. But it's not coming. Okay. In 2021, Henry Wagner Jr. Award. We in every SNA meeting we go and always look at the last day of the meeting, who is going to get the Henry Wagner Award of that year. And people who lifetime they wait for that. And I was lucky to get twice, 2 consecutive years, Henry Wagner Awards by the Society of Nuclear Medicine as the best researcher of the year. And then after our work, there is a lag page. Okay. So an Indian innovation changed the global market. How? Then you will see the left-hand side is Rage Bio, which is very famous for known. This company was started in 2021. And he, after our publication in JNM, he submitted that work, JNM as abstract. He submitted this work to the FDA for approval to give a phase 1 trial. And they told, okay, it may work in India, but you have to do some white population in America. So if that result will be matched to Indian result, then you don't have to do a phase 2 trial because already 91 patient data is published. It's a phase 2 trial. We can give you phase 3 approval. So he did 17 patient only phase 1 trial, phase 1B trial, and they got identical result. We got 44% response rate. They got 46% response rate. Identical result. And FDA immediately gave him a phase 3 trial. As he got the phase 3 trial approval, before on 24th of December, 2023, called me, Dr. Bal, we've been sold for $4.1 billion to BMS. That is Bristol Myers. We purchased this company for $4.1 billion. Actinium dotatate in neuroendocrine tumor who have failed lutetium dotatate. And then right-hand side, you can see there is the senior vice president and in charge of theranostic is Jeevan Big. He wanted to discuss how we can have similar Rage Bio. So every day you cannot create another Rage Bio. So this is what the Indian innovation. And now you can see how many companies have been now. This is Rage Bio, BMS, now Radiomix, Oranomed. There are several companies now working on actinium dotatate. And there are 10 companies now in the US who have been trying to produce actinium in a cheaper way. Because the sole supplier was ITM in Germany, and now everybody wants to produce through the different methods of using cyclotron, using radium-226 and all this. Now there are ways. And then bismuth-212, only problem with bismuth-212 is that it has got a half-life of 10 hours. So whereas 10 days versus 10 hours, if it is half-life is 10 days, you can send all over the world and send anywhere from North Pole to South Pole and still activity is hardly destroyed. But if it is 10 hours, it has to be locally available. It has to be. And getting this lead-212 is difficult. So coming to the lutetium PSMA 617 beta therapy, this was my student Madhav's PhD thesis. And both Sanjana and Madhav, they each one have got more than 15 international awards and recognition. And both of them, I have sent them to do medical school in US. They are doing, Madhav is doing 3rd year medical and Sanjana is doing 2nd year medical school in US. So after doing MSc PhD, now they are doing medical school MD. They will be MD PhD shortly. And so this was the Madhav's PhD thesis. So we had the first initial result of 23 patient to 31 patient we published in European Journal of Nuclear Medicine. And this you can just on This pictures 1,000 words gives 1,000 words. You don't have to. You can see the extensive disease just disappearing. It's not Photoshop. It is actual patient images. This is not AI generated. Then Madhav thesis was on dosimetry, and first time we did 26 patient lutetium dosimetry, PSMA dosimetry, and published in clinical nuclear medicine. And Madhav was given, and our group was given as the best publication in EJNM, is the highest cited paper of that year. So we got in Barcelona this award. Then subsequently, Vision trial by Oliver Sutter designed, because by the time this Novartis was very much interested in, so they purchased the AAA and they started a phase 3 trial and outsmarted the Australians have done phase 2 trial called therapy trial, and then that was only a small number. So they did 900 odd patients and quickly it was presented in ASCO, and within 1 week published in, because there is an embargo, when anything that is published in ASCO, it cannot be immediately published. So after 1 week, it was published in NEJM, and then 1 month later, they got FDA approval for this Pluvicto. This was a very big trial. And then the survival outcome, again, 15 months, which we got 15. When we presented our data in SNM, Dr. Richard Baum, he told, because you are using Indian lutetium, your result may be bad. We are getting 48 months. But when the Vision trial result published in NEJM, Dr. Baum was also one of the co-author, and it was 15 months. So I'd say, if you do science in the right trial way, whether it is you do in Africa, or you do in East India, or you do in America, it will be safe. What people do is they try to manipulate the data. If your data is manipulated, it will not be reproducible. So the reliability of research is reproducibility. If you can reproduce similar data, it should be the most reliable work. Then what we did, another interesting thought, can we use real world data? We did the first line, as a first line treatment. Early, what the radiotherapists are doing and the medical oncologists are doing, if it is deprivation, androgen deprivation therapy, then ARPI, then they go to the taxane. After the taxane is given, then they come to the nuclear medicine. Can it be as a first line treatment? And this just published, we had 40 patients, ECOG more than 2. Most of the trial, they will never take any ECOG more than 2. They will always take 0 to 1. Worst case, it will be 2. And then it is 72% response and only 22% activity. You can say 12 months versus 17 months, PFS and OS. So this around 15 months, anything you use, docetaxel, anything, ARP, everything is 15 months in prostate cancer. Then large volume data. Can you use a large volume metastasis with lutetium-DOTATATE? Yes, you can. This is the publication we have demonstrated. So these are all pilot to say that go and do this. This is the hypothesis we are giving. Go and to do this. So this you people have to carry forward. Then coming to once the Pluvicto fails, what is next? You give actinium PSMA 617. So this was again from the same Kratochvil group from the Heidelberg. They use actinium PSMA 617. This is not the bismuth. This time they did actinium PSMA in 2 cases. And this become the image of the year in JNM, because the results are so striking. Then Mike Satke from South Africa, he used again bismuth PSMA 617, demonstrated also good result, but you know the PSMA 617 is got problem with bismuth has got only very short half-life. So then we did, Madhav continued working on, we did our group, we had 31 patients. Then we continued working on this with those who failed on Pluvicto, we used them, and you can see the median PFS 12 months and OS 17 months. Those who had already end up the tunnel, they got very good results. You can see the results. You can see your battery is running low. Okay. Can connect? Okay, that's fine. I'll be quickly finishing. So these are the result on 56 patients we published in European Journal of Nuclear Medicine, and then it is Lancet Oncology, 488 patients. And this is the world's largest data. With Mike Satke and myself, we collaborated, and 4 different institutions have contributed: Australia, India, South Africa, and Germany, and 488 patients, and so excellent results. And you can see the waterfall plot. Low battery is connect. I'm just at the last part of my talk. So 68% of patients reported xerostomia after the first cycle, because unfortunately, the Westerner, if you ask them, you go to a restaurant, ask what will be the spice level, they say 0 or maybe 1 or 2, but Indians will tell infinity. You add all the bottle of chili on the plate. So maybe our salivary gland is stronger. We got only 33% xerostomia, whereas the rest of the world got 68% xerostomia. So this is what. And then, that's finished. And there are several companies now using actinium PSMA 617. Several companies, you can see. Yeah. So you can see several companies are doing with that. At least seven companies are doing and registered in CTRI. Then coming to the last part, which is my mostly research and yet to be a very big trial to come, is the managing the radioactive refractory DTC. I am fortunately a member of the international committee to only non-European, non-American to represent rest of the world. They say rest of the world. So I am representing the rest of the world in that committee to define what is RRDTC. And it's a very real challenge. Why it is difficult? Because if it is low risk, recurrence rate is 1 to 3%. If it is intermediate risk, it is 10 to 12%. But if it is high risk, 50 to 60%. But the minute it becomes radioiodine resistant, the survival drops to 10-year survival drops to 10%. So it's real cancer. So how to manage? Because iodine doesn't go. You have to find out what is the availability. Since 2012, we have got all the TKIs. You know how the TKIs work. They are lot of, I don't know why Indians and Asians, they have got very high hand-foot syndrome, the tolerance rate. Even I have a patient who is only could not tolerate even 4 milligram of full-length 4 milligram. Our highest dose is 14. We cannot exceed. Even the minute you increase to 16 or 18, they're out. So we have to find out some way how to do the radionuclide therapy, which has got always a better safety margin. So we have got cancer-associated fibroblast, and their product is called FAPI. FAP, that is fibroblast activation protein, and you can use a small molecule inhibitor, or you can develop an antibody against this enzyme. So then you can have a monomers, which is good for imaging, but you can have a dimer for therapy. And that is why now there are many companies called FAPI46, 3BP is 2286. And then we have developed a molecule called GluFAPI, which is now been patented all over the world. Our first image of the month in triple negative breast cancer, and we could save this patient for 22 months. Finally, she died. And this was published in the image of the month in EGNMR. So this we did from the starting, we tried 15 molecules. Every molecule we tested, and finally we stumbled on one molecule, that is GluFAPI. I will go to that. I'm not going to the details of the research. This is all published research. And then if it is you have to have radionuclide has a physical half-life. The pharmaceutical has got a biological half-life. The physical half-life and biological half-life to match, then only you can have a big, efficient, effective half-life. Suppose you have got FAPI4, has got a biological half-life of 10 minutes. If you put actinium to FAPI4, that means you are using a Benz Mercedes body with a Maruti 800 engine. It will not go anywhere. It will look like a big machine, but it will not go anywhere. Or you reverse it. If you put a bench Mercedes machine in a Maruti 800, the minute you speed up 150 kilometers, all the parts will go away. So that's why you are wasting resources, because the biological half-life as much as. So in the process, we did all the dosimetry work, everything, Sanjana's work. So we did demonstrated that we can increase the biological half-life to 89 hours. From 10 minutes we increase. This is the best of the standard molecule till the work. So we did initially monomer, then dimer, then SF happy, then finally we stumble on group happy. You can see, take a model, thyroid cancer model. You can see it over the time. You can do for 3-day, 4-day imaging and see that still it is retained. We did up to 168 hours. Then head-to-head comparison in DOTA SF happy in radioiodine resistant thyroid cancer, which is my first love. So this was published on the cover page of Thyroid. This was the Indian work published in the cover page of Thyroid, showing the novel fibroblast activation protein inhibitor-based targeted radionuclide therapy for RRDTC, a pilot study in 15 patients only. They put on the cover page. This is after 82 years, first time, other than iodine, some radionuclide used for therapy of the thyroid cancer. Then there was an editorial. Therefore, there was an editorial in EGNM. Therefore, the radiolabeled can act as a progenitor for the radioligand therapy in aggressive variant of dedifferentiated thyroid cancer, where the therapeutic options are still limited. In this context, the study by Balal et al. Considered the potential for theranostic approach that may represent a good opportunity. But we are doing in between also. What he was predicting, we have already done, and in the next year, we published in Thyroid on how many patients? 73 patients. This is the long-term outcome in radioiodine-resistant thyroid cancer treated with lutetium fatty. And the median PFS was 29 months, and OS is 32 months, and only 4% patient had thrombocytopenia. Nobody has got grade 4 toxicity. And you can see this patient is coming. No, still, I think there is a lag page. I don't know. Yes, now it is coming. You can see this image. This is a 7-year-old boy operated at a Tata Memorial Hospital, and then 35 years. When he was 35 years, he has come with all extensive meds, and this time no radioiodine concentration. He was given 600 millicurie when he was between 7 years and 10 years, and now there is no iodine concentration, but he has got everywhere. So we treated this patient, this Dr. Kavitas, and this patient is known to this patient, and we treated and is doing well. Now 7 years is doing well. And then we developed this molecule. I am the co-inventor of the Gloop Happy. It is registered in FDA, is registered in US and Europe and India, China, Brazil, and all these countries. I am co-inventor of this molecule. And this molecule, for your good news, this molecule has now been purchased by Telix in $162 million. You can see this. This is coming. See, you can see the extensive meds, near complete remission with the therapy. This is a long path of 3.5 years. There are many people on the way. Many people have contributed significantly. I acknowledge my mentors, the role models, colleagues and students, and many more, my patients. All of them helped me. And I was a more clinician scientist than a clinician. I get fed up with any routine work. Within my span of attention is very short. With anything you do routine, it has to be done at the spinal level. I want the cortical itching. So to do something which is, I always, all my life, I always challenge the established dogma. Where is the evidence? I always ask, where is the evidence that it works? And if you have culture that habit, questioning all the time. Questioning means you are learning. The minute you accept something means you are passive. So this is how, this is in the Arni Majaperi, which I am talking, the Arni Majaperi was there with Schlumberger, with Purio Pacini, and my Indian mentor, Professor Padhi, and Dr. Na. Dr. Narendra Nair, whom I contact. And we have now 24 MD students in our department. Now it has increased another 6, so it will be 30 MD students. We have got 31 senior residents, and we have got 11 DM students. We have got dozen of PhD students, and we have got 30 MSc students. So the department, when I joined in 1990, had one senior resident. And now, the time I just superannuated, we have a huge array of students who are the real backbone who do all this work. We only give them ideas how to go. We just supervise them. So the students are always the backbone of any department. You have to be always surrounded with all bright brains, questioning you all the time. So you'll be always running, or you must know the answer. And of course, I acknowledge my family who are I don't know what is coming, still not coming. Okay. This is my daughter, who is a medical oncologist from Memorial Sloan Kettering. She's currently associate professor in UAB. She works on myeloma. She says, Papa, except myeloma, I don't know anything about oncology. She has forgotten everything. She spent 6 years in oncology, but she says, except myeloma, I don't do anything. And we have been blessed with in October, 2 months back, I've been blessed with a granddaughter, and we have got a grandson. And this is my son-in-law, is an interventional cardiologist. And this is my small family. And we have added just one more member now. So 6 people, that's what all about my, thank you very much. And the best way to predict the future is to create it. This is the path to the future will be education of nuclear medicine therapeutic specialist as a responsible physician. This is a hot topic now. You must create critical mass to take to the next level. Otherwise, after some days, the radiotherapist will tell, okay, we'll do alpha therapy. Then the endocrinologist will tell, we'll give cancer therapy. And uro-oncologist will give Pluvicto. Because we have to not only see, when you read a PET scan, you give some report. Madam, my friend, she is sitting here. She will say, okay, this report is not good. She will throw it to the dustbin if she likes it. Or she differs. She will call you. Hi, Dr. Pradhan, what is this report you are writing? I don't care. What is this? You must review this. But when you are a therapist, you are responsible for the patient. Your knowledge directly benefits. Just like a good lawyer will save you. Even if you are murderer, you will be saving. So a good physician will save the patient better than when you are doing a reporting, whether you are doing nuclear cardiology or nuclear oncology, you are giving a piece of paper, read a report, and that the consultant will accept or not, doesn't matter. But when you are doing therapy, you are so, and radionuclide therapy is not like in radiotherapy. Radiotherapy departments, radiotherapists manage the toxicity. But who delivers the dose? Of course, they sign on the piece of paper without understanding many times, sorry, with due apology. So they say, okay, TBV, all this only they see the line, how it is critical organs are saved. But in nuclear medicine, if you are dispensing 200 millicurie of iodine, you are answerable to the patient, not anyone else. That's why I envisioned in 2008, submitted a proposal to the Academic Committee of All India Institute to start a DM program in nuclear medicine therapy. And it took 7 years to convince. They will always ask, is there any other place where it is this program? I told Dr. Malhotra was head. He told me no. Then they will tell, okay, wait. But the day I became HOD in 2012, 2013, I went to the meeting. I told, can't All India Institute be the first in anything? Should we start MD program after Sanjay Gandhi? Why can't we be the first? So I, with my vociferous propagating, I got it approved within 1 year. It was December 13, I became chairman, and December 14, next year it was approved by all the academic committee, governing committee, finance committee, all the committee. And 2015, our first student was enrolled. So it was only 1.5 years took when I became the chair. I got it approved. And now we have got critical mass all over, people going there, and many of them are abroad also doing very nice things. Thank you very much.
Thank you, sir, for this wonderful oration. I would like to invite the Faculty of Nuclear Medicine Department to felicitate our esteemed speakers.
Our dear friend Punita ma'am, you can honor us. We are not competitors, we are collaborators. When Will Jackson will fail, we'll give the dolls. Don't worry. But you throw it to the dustbin also, I know. Please. Yes. I know Dr. Punita long back before you guys were born. We lost many bright stars which are dedicated to the Sanjay Gandhi, but we have Dr. Biswal, Gandhi, this is the time आप इंजन हो हम लोग डब्बा है आप बनाएंगे तो बनाएंगे I don't want to take the name of the told me.
Malaysia,
Now, Professor Pradhan sir will be felicitating Prakash sir.
Now, Professor Pradhan will felicitate Dr. Vineet Mishra. Faculty of Nuclear. I request the Faculty of Nuclear Medicine to felicitate Professor Pradhan, sir.
We have been since 90, you know, the product family. When I was a sir, the product was over there. So,
Something. Thank you.
What up? Thank you.
Thank you, everyone. To conclude the program, I invite Professor Manish Dikshit, sir, to propose the vote of thanks.
Thanks, Sisti. I thanks all of you, especially Director SGPGI and Dean SGPGI, who has graced this occasion without his busy schedule. I would like to thank Dr. Bal for coming so long and delivering such a nice thematic talk as well as to motivate us. what he says is very true, that if we change the pathway, that is the real benefit of our society. So we all have to work in the same philosophy, because philosophy never dies. The people will remain with their philosophy. So with this, I thanks to all of the esteemed faculty of the institute, as well as all technical member of the department, students, as well as all people who are not here, but their blessing continues to with us to keep us motivate and grow. Since we did in last 36 years, we will continue for the next 70 years. I hope that with this all, we have another foundation day in near future with more productive work in our pathway. So we also thanks the organizing, especially the mic people, that this auditorium facilitators or staff who with him all this facility will be the possible, especially the cameraman who is always clicking. So all these people are supportive, because without them we cannot remember. Because if you see the 10 years back photo, we say, okay, this guy is so thin, now this becomes so fat. So this is all of these people. So, and also the fund, we got the fund from the CEPLA Oncology for this program to be initiated or make a functional feasible. With thanks to them, and with thanks all of them if they finish our food, which is lying outside of this hall. Okay, so please join us for the lunch, and hope we will meet very soon again. Okay, so come join for the one group photo. This is all tradition, so maybe we can take the anthem first and then go for the photograph. That's good.
May I please request everyone to stand up for the national anthem?
स्लो है थोड़ा
So इसमें एक लंदन है भारत भाग्य विधाता जय जय जय
group photo